Good morning. I want to welcome everyone to the Venous session for today, which is Thursday the 11th, 7/11. And thank you, everybody, for coming. I want to mention, too, that we have a program this morning that goes from 9 to 12. And due to the necessity to have as many presentations as possible for the CME credits that you receive, there isn't a built-in break. But if you feel that you need to get up and have a break during this session, please do so. And we have a special treat at 10 o'clock. We're going to have another patient testimony to talk to us about what it's really like to have DVT yourself. So Dr. Razavi has to be in the other room for some of this session, so I'm going to moderate this session, and I'm going to invite Dr. Razavi to the podium to give the first talk about cost effectiveness in endovenous therapy. Dr. Razavi is Chief Medical Director of the EndoVascular section at St. Joseph Hospital in Orange County. He's a vascular interventional radiologist. Welcome.
Thank you. Thank you, Patty. What we're going to concentrate on today, I know the few talks are on the superficial venous disease. That's established treatment, and there is a lot of information on cost effectiveness of all of those, and the alternatives are few. I decided that I'm going to concentrate on the deep venous system today. Because it is new, a lot of insurance companies are looking at it. In fact, there is a real threat from most of the insurance companies that they will not cover venous stenting. And there's a lot of rumors out there, and so society, on a professional society level, everybody's getting involved to make sure it doesn't happen, but it's a real threat that they just came and said, we may not cover it. So it's important to do some cost-effectiveness analysis on these issues to see if what we do really is cost-effective, or are we just making things up. These are my disclosures. The burden of DVT, you all know the burden of DVT. It is estimated that about 56 to 182 patients per 100,000. That's the estimated incidence. VTEs account for about 250,000 admissions per year. So that's the admission into the hospital with the diagnosis of for venous thromboembolic disease, not a secondary. And 59 to 75% of the patients who have DVT is hospital acquired. So you can see that's a huge deal. And it's the most common cause of preventable death in the hospitalized patients in the US at a total annual cost for DVT alone, not considering the PE, DVT alone of $6.1 to $9.3 billion direct cost to US. Now, post-thrombotic syndrome, what is the cost of post-thrombotic syndrome, which is the complication we're trying to avoid in these patients? 12% of new cases of chronic venous disease and venous ulcerations are due to PTS at a cost of over $400 million per year. This is the 2000 US dollars. And the ulcer is responsible for loss of 2 million workdays per year in US. That translates into about 1 to 1.65 billion of lost productivity a year in US alone. And this is an assumption of PTS incidence of 20 to 37%, which is low. We know that number from the SOX trial is closer to 50%, and about 40% resulting in loss of workdays, which is also low. So this number probably is closer to 2 billion lost productivity a year rather than 1.6. Now, this is a very interesting analysis published in 2006 for the data up to 2004 from the pharmametric database, which adjudicated medical and pharmaceutical claims for U.S. health care plans. Okay? And they took a sample of those patients and looked at the cost of patients with DVT. If you concentrate in that upper line here, this is PE, DVT, PE together. This is just DVT on the upper one. The cost of these patients, annualized cost of these patients per year for the plan was $7,000 before they got DVT, and jumped to an annualized cost to the payer of $17,000 per year of the life of that patient after the DVT. So this is something special here. Something we know that the cost goes up. We know that this is something huge here. Now, if you look at the annualized direct cost of DVT and PTS, post-thrombotic syndrome, it's about $20,000 per patient to the plan after they get the DVT. That's a big number. So that's what we're trying to avoid, $20,000 per year. And I will come back to some of these in a second. All costs associated with VTE, venous thrombotic agents, this is cost of complications also. It was an updated analysis, and I encourage those of you who are interested to actually take a look at this paper. It comes from the impact database, which is the health insurance claims. And from 2004 to 2008, all inclusive, the dollars are in 2004 dollars, and a sample of patients with venous thromboembolic disease were matched to a sample of patients who did file insurance claims, so they were sick, but didn't have DVT. And endpoint was 1 year after the index diagnosis, so they only calculated the cost for 1 year. So the cost of PTS is probably not quite captured in this group. And only provider payment was considered. So pain, suffering, loss of work, none of that they calculated. Only what is the cost to the payer. And this is what they come up with. Look at that. Look at this graph on the left side. This is the VTE group. This is the non-VTE group. Okay, this is the claims. And as you can see, there's a difference of about $16,000 extra for the cost if the patient develops DVT or a PE as a result of it, that the cost goes up by that much. Okay? And most of those, it's not in the pharmacy. It's not the drug. Look at it. This is the component of the pharmacy is very small as opposed to the hospitalization and the outpatient care. In fact, if you follow these patients for 5 years after that, it's the cost of hospitalization that dominates, that tells you that the old O'Donnell paper from the 70s that said these patients get hospitalized, these post-DVT patients get hospitalized an average of 3 times a year, this is actually correct to date. So the importance of cost of care is that the traditional methods that we usually measure outcome, which is morbidity, mortality, patency, all of that, are really not sufficient in today's practice of medicine. We need to consider cost and the cost per unit of efficacy, however we measure that. And I'll go over some of the examples with you in a second. The other issue that we need to be aware of is willingness to pay. And the insurance companies and the government define that this is our willingness to pay. And I'll come to those numbers in a second so we all understand what that willingness to pay is for these patients. And the concept of quality or quality adjusted life years, for those of you who are not familiar with that, I'll give a very quick tutorial on this so we all understand that. We all sort of are familiar with this or understand that for any treatment, there's a cost and there's an effectiveness. And if you're along this path, usually the new developments by industry is if the effectiveness goes up, so does the cost. Whether actually the cost to them is higher or not is immaterial. But if the effectiveness is higher, they charge more for it. So if you are in these 2 quarters or quadrants, then to compare 2 different treatments together, you have to do a formal cost-effectiveness analysis. If you're out here, forget it. It is called dominated. That means it's not cost-effective. And I can tell you in the DVT space, and certainly in the arterial space next door, we all know of a lot of technologies that are there, and they still sell pretty good. And few are down here, unfortunately. So keep this in mind as we go forward. Let's define quality-adjusted life years. Quality, you see this all the time. So what is quality? Quality is this is an attempt to measure the value of health outcome of any intervention or any therapy or any drug. It is expressed in the number of years lived in perfect health. So the assumption is one quality, if you get the intervention X and it has a 2 quality, that's 2 qualities in perfect health, 2 years of perfect health, and that's 2 qualities. And the model is based on certain assumptions, obviously, and it's the accuracy of these assumptions that determine the accuracy of your calculations. And the quality gained is the number of years of life in perfect health times some utility index. What does that mean? It means if, for example, you have claudication and you treat that and the pain goes away, there is a value assigned to that pain. So it's called utility, measured by visual analog scale, or time trade-off or standard gamble. These are different statistical methods that they measure that utility value. keep in mind it's the years of life times this utility value. That becomes important in a second when I discuss the cost effectiveness of DVT. So quality gain would be single index of quality and quantity, which is a change in utility value, let's say pain, or we could call it patency, for example, in the SFA if we want it, times the duration of the effect. So if you put a venous stent in there and that stays open for 5 years, or versus 1 year and it's thrombosis, that changes that duration of treatment effect, therefore it affects the quality gain. So it's a measure of cost. Now, incremental cost effectiveness ratio is when you compare two QALYs, so two different treatments. And that's a measurement of the cost per QALY, okay? And so it's incremental cost of any treatment divided by incremental cost of one treatment versus the other. So let's take two interventions, intervention A and B. One costs $1,200, the other one $2,500. For that $2,500, you get a little bit extra QALYs, okay, a little bit more duration effect. So your incremental of B over A, so if B costs more and the QALY was less, we don't even have to do this calculation. So it is more, so you gain in QALY based on cost, so your incremental cost difference is $1,300 for a difference QALY of 0.7, so your incremental cost effectiveness ratio becomes $1,857 per QALY gain. So what does that mean? What is the threshold for cost effectiveness? Is it, $1,000, $10,000? What is it? What is considered cost effectiveness is by both private and governmental insurance agencies in US dollars today is $50,000 per year. That's the cost of living one good year. This is based from the 90s data, okay? So this is pretty old. Now you may say 50,000, that's a lot of money. But if you consider the fact that to keep a dialysis patient going for a year, the cost is actually a lot more than that. So for dialysis patients, the accepted number is $129,000 per year. And a lot of health economic experts are pushing that. They say that 50,000 is too low, and it needs to be closer to that dialysis group, which is 129,000, which is probably accurate. 50,000 is actually low. So when we calculate that incremental cost effectiveness ratio, the 50,000, if it's more than 50,000, it's considered not cost effective. Less than 50,000 is considered cost effectiveness. And there are a lot of, even inside the government, inconsistencies. And look at this thing. According to the FDA, the value of life is $7.9 million. According to the EPA, is $9.1 million. That means that 50,000, you have to live 100 years to get that. According to the Department of Transportation, it's $6 million. These are all government agencies. Why is that? It's because if that $6 million is higher with the Department of Transportation, they have to spend more money on the highways to make them correct them, so the fatalities go down. Insurance companies pay more, and they lobby the government to keep that number low. And so does the EPA. As you can see, how industry obviously plays a role here. The Homeland Security does not have a number, but it's 100% higher than the highest number of any government agency. And Pentagon death benefit is $500,000. So if you have a 22-year-old soldier who goes to Afghanistan and gets shot by Baba and dies there, the value of that 22-year-old's life is $500,000. If the same 22-year-old comes to Texas and gets shot by the same Baba, that value is 100% more than $7.9 million. That's interesting. I find that interesting. So back to cost effectiveness and back to DVT. Now that you all know what QALY is and incremental cost effectiveness ratio. So this is, the data is very little, very few. So this is based on Endon's Cavant trial, which was published a couple of years ago. That was a randomized study of catheter-directed thrombolysis versus anticoagulation. And they did a cost-effectiveness analysis based on that, and the model captured PTS, recurrent VTE, treatment-related adverse events over a lifetime of the patient, and they assumed that the patient was 50 years old when they got the treatment. And the input for that value that we talked about, the pain, it was from the Cavant trial. And this is what they come up with. Standard anticoagulation, they got 31.68 QALYs versus catheter-directed thrombolysis of 32.31, and that's the cost difference. Now, before you say, this is only less than 1 QALY, the cost-effectiveness analyses that are done for some of the direct thrombin inhibitors, apixaban, for example, over low molecular weight heparins, which was shown to be highly cost-effectiveness, their difference in QALY was 0.09, okay? So that's just to put things in perspective. So according to this calculation, that gives you an incremental cost-effectiveness ratio of $20,000 per QALY gain. This is far below that $50,000 value that we talked about that the insurance companies are willing to pay. And in fact, if you looked at their modeling, any way you changed the assumptions that they made, in all situations, the cost was less than $55,000 per QALY. So chances are this is a highly cost-effectiveness therapy. And their calculation also was that there is a probability of 82% that this is a cost-effectiveness treatment at $50,000 per QALY. Now, there are a lot of weaknesses of this study. We'll talk about it in a second. One is that the utility they used, and remember we talked about that calculation of QALY had a utility, and cost data were derived from the Cavant. Now the Cavant had a very high post-thrombotic rate, much higher than we get in our practices, and probably is going to be much higher than a track trial will show. And there are reasons for that because of the enrollment and all of that. They assumed a 0.4%, almost 0.5% increase in fatality due to catheter-directed thrombolysis. And I can tell you, having done close to 1,000 of these, I have not seen a single mortality due to DVT thrombolysis yet. So it's very low. It's likely to be less than 0.5%. And they also included transportation costs because they transported patients from all over Finland to one center for treatment. And so that cost was added into that. They only considered the perspective of the payer, so they did not consider the cost to the society, cost to the patient, et cetera, and they used the Markov model. I won't get into the details of this Markov model, but Markov models are very sensitive to assumptions. Weaknesses of Cavant trial that will affect the cost-effectiveness ratio, the high PTS rate of 41.1% and a relative risk reduction of 26% they saw. Most of the literature on DVT shows 30% or more relative risk reduction. So that means your utility value is actually less, means it becomes more cost effective. They had a high complication rate, they had a low patency rate, the stent uses were low, and they had a very prolonged infusion and hospitalization time, an average infusion of 2.4 and hospitalization days of 5.3 days. And these models are very sensitive to hospitalization days, as you know. If you look at the US census, the average today, the average infusion time is 1.3 and hospitalization days of 3 days. That takes your incremental cost effectiveness ratio for 1 day to only $7,000. Highly, highly cost effective. If you could do a DVT in 1 day, that ICR ratio is 7,000. Remember, the threshold is 50,000. So keep that in mind. This is likely to be very, very cost effectiveness. Despite the fact, all the weaknesses of the Cavant trial, the data wasn't as good, and all the weaknesses in their modeling, it was shown to be highly cost effective. In fact, in all scenarios, at a willingness to pay threshold of $24,000, DVT treatment, getting Cavant type results was cost effective. Now, so in whom is it cost effectiveness? Obviously, all patients with proximal DVT who are at low risk of bleeding with catheter-directed thrombolysis, which was the inclusion criteria for Cavant. Particularly those who are at risk of PTS, proximal DVT, recurrent DVT, advanced age, female gender, high body mass index, thrombophilia, those people who have varicose vein, abdominal surgeries, things of that sort. The only thing of that list that I argue with is advanced age, because when you have an advanced age, if you have an 84-year-old with DVT and is on a wheelchair, the chances of post-traumatic syndrome in that patient is low, and then the life expectancy is low, therefore affecting the cost-effectiveness ratio. The younger the patient, the more cost-effectiveness this therapy is. One more interesting data to just put things in perspective. Expenditure for PAD-related treatments, this is from Medicare data, $4.37 billion in US. Cost of treatment per patient for PAD, about $14,000. These are the guys next door. Total US cost of DVT, 6 to 9 billion, so more than PAD. And expenditure for cosmetic procedures in US, 11 billion. And I'm not talking about cosmetic drugs or something putting on your face. I'm talking about cosmetic surgery procedures, 11 billion a year. So that tell you where our priorities are in US. Oh, doesn't advance to my, okay, so in conclusion, all interventionists should be familiar with the cost-effectiveness analyses, at least at the level, very, very low level definitions. There are very few publications in this arena. There's a lot of opinions, but actual data like the paper I just showed you, that's the only one. And we will have more data as soon as the TRACK trial is done, and I can guarantee you that data is going to be analyzed every which way. And it appears, however, that at even low levels of efficacy and high levels of PTS, this treatment is highly cost-effective. Thank you. Did you? Yes. Any questions before my apologies, I have to leave for a few minutes. No. Great. Thank you.
That's great. Yeah, thank you. That's a very stimulating talk. Got work to do, don't we? All right. Then our next speaker I'd like to welcome to the podium is Michelle Sloan, who is a nurse practitioner who is in the cardiovascular arena, endovascular arena with a group in Michigan. And she has been a speaker here before, and we welcome her back to talk about the essentials of billing for venous therapy.
Hello, I wanted to thank everybody for coming to this session. The title of my talk is the Endovenous Therapy, Starting Your Practice and Appropriate Patient Selection to Ensure the Success of Your Young Venous Program. I thought this was a pretty big title when I saw this and kind of giving me a lot to talk about to ensure your success. So I have to have a disclaimer with that. So just a show of hands, I wanted to see how many people in here have been doing veins for a year or less. Venous treatment. Okay, a couple of you. How many people have found it difficult to capture or bring these patients into your office or find these 30 million patients with venous disease? Okay. Well, hopefully my talk will give you some pearls on how to make that a little more efficient and to consider some different marketing strategies for finding these patients. So first of all, just starting your practice, creating that space. This is pretty basic. It's a checklist, first of all, mastering the technique where you're learning that, designing and creating that space, making sure it's lighting, it's warmth, it's aesthetically pleasing, equipment, figure out what bells and whistles you want on it, staffing may be a little bit more tricky with trying to find a good RVT that you can be confident in and work with and help. But the one thing that we often miss here is the marketing component, and that's what ties your space together with getting the patients into that space. So who's in your waiting room? If you look at this list up here, the elderly, varicose veins, family history, obesity, I want you to think about your waiting room and a little bit of a homework assignment when you go back to your office. I want you to walk out there when it's kind of busy, at 11 o'clock or whatever, and just kind of look in your waiting room and think about the percentage of patients that are out there that may be at risk or have varicose veins or venous insufficiency, claudication, that we may not be addressing or finding. I think you may be surprised with how many patients that are out there. And even though we know all these risk factors and we know all the signs and symptoms, are we addressing this with every single patient visit? We're a half hour behind, it's Friday afternoon. Are we taking the time with all of our patients to evaluate them for venous disease? Well, the spectrum of significance is very large for venous disease and how it presents. And where do you start? What patients are you looking for in your practice? Are you just looking for those that have visible varicose veins? And are we looking at their legs on every patient? Are we just looking at and engaging the patients who actually are complaining of leg symptoms, heaviness, fatigue? Or are we just relying on referrals that are coming in from outside sources to feed our venous program? The spectrum of significance, where do we go from here? So what are your goals? Where do you expect to be in 1 year, in 5 years, in 10 years? Are you going to add services? Are you going to do phlebectomy, sclerotherapy? Where do you want to go with this? And knowing that direction. Again, who are you going to attract? So once you start getting your name out there as being a venous expert and working with veins, you may find people that are coming in with multifactorial etiologies for their symptoms and complaints. So figuring out, is this truly venous reflux that's causing these problems, or is it something more and something different? Knowing how to work up all of those differentials. And then also, what are your limitations going to be? Are you going to do wound care? Who's on your team? Who are you going to refer those more significant cases to? Or when it starts to go outside of your realm of what you're comfortable with treating, where are you going to refer those patients, and where do you go? So build it and they will come. So build it, your space. Now we're waiting for those patients to come in. Well, how do they know to come, and are they going to come? There are a lot of myths and biases out there, not only according to patients, but also with our own healthcare providers, primary cares. You know, it's just a cosmetic disease. It's not debilitating. Really nothing works for them. Just put them in compression hose. Do they know what the latest and greatest technology and research has been showing? So we need to, and at Eastlake, we've used this form. It originally was for peripheral arterial disease, and then we found a lot of patients in screening for arterial disease that had venous disease. So now we made this form to capture both of those patients and kind of help sort through the difference in their pain and their symptoms, because both of them can have very vague symptoms or subtle. So this form, that first paragraph, kind of gives them some information about PAD and venous disease, educates them. I mean, we all know an educated consumer is a better consumer. And it starts that conversation. So are we, if we're busy and we don't have that time to address a new problem or search for a new problem for our patients, this kind of starts that conversation right off the bat with them. And it educates them and plants the seed. So maybe they don't have symptoms now, but maybe in 5 years they're going to start to have some symptoms. So ensuring your success with patient selection that you have, taking the time to investigate and really learn and understand what their primary complaint is. Is it the swelling? Is it the arthritis in their knees? What I can do to help treat their venous disease, is it going to work? Is that what we're going for? They may be chronic and subtle, and again, multifactorial etiology of the pain or swelling that they may be suffering from. And talking to patients about that whole conservative period that they have to go through before we can do any intervention on them. And I'll explain to our patients, this will help if you're wearing compression stockings and elevating and doing all that. This is going to help you see the pain or the symptoms that may be resolved or improved after we potentially would do any ablation. And then again, identifying the source of reflux and its anatomy. Is it proportionate to their symptoms? Do their symptoms, is it disproportionate? Should I be looking for something else going on with these patients? That's another thing that we need to make sure that we're doing. The quality of your testing. Do they meet the insurance requirements? Making sure that you're choosing or selecting that appropriate and correct patient. And the last thing you want to do is have this patient that comes to you with all these complaints and issues and symptoms, and you do a procedure on them or you try to treat them, and they come back and they say, you know what, I see no difference. Those patients are frustrating, and was that truly an appropriate patient to do something with? Maybe we should have spent more time to figure out what was their primary concern and what really may have been going on with it. discuss the expectations and plan. We've had patients that come back and they say, well, I thought this vein was going to be gone. So making sure, they know that ablation is not a cosmetic procedure. It's more to treat those symptoms, what that treatment plan is. So if I'm putting them in the compression stockings, and when they come back, this is what I want to know. Have they helped? What are they doing? If it hasn't, here's our options then at that point. Are there going to be multiple procedures, or we can stay in compression and do that conservative therapy? So letting them know. And satisfaction absolutely is the key. A happy patient will bring you more patients. So if you do all of this work up front, this will help. In our practice, when our patients have venous reflux, they'll come and see me in our clinic, and I go over all of this with them. I talk to them about their symptoms in depth. I talk to them about the options, and we get everything going there. So I'm doing all of that education and groundwork. Consider a quality of life questionnaire. I think that's a great idea. Have them take that before and then maybe after to see the difference there. And creating a portfolio. So if you have patients that can kind of tell their story, these were my symptoms before, these were my limitations, these were my complaints, and then after, and how things were helped, and maybe even putting some pictures in there. And then having that available for your patients to see maybe in the waiting room or in their exam room. So build it and they will come. Again, putting everything together, it's your marketing piece. You want to make sure that you're bringing those patients in. And, keep in mind that these patients can go many different places. They can go, elsewhere to get vein treatment. And if you want to keep your patients in your practice, let them know what you're doing and that you can help them. And this process can take time to get everything set up and build your name out there. So in conclusion, first of all, you have to set that stage. You have to get everything ready internally. Venous disease presents anywhere along a wide continuum. So who are you going to look for? Who are you going to attract? When are you going to get those patients? When they're claudicating, when they have ulcers, when they have visible symptoms? When do you capture them and treat them? Take time to listen to your patients and their complaints. Again, that's key for your success and for their happiness. And the appropriate patient is the one who's satisfied. So you did something, you treated them, and they got good results. Success is synergistic and not random, so make sure you have a good team in place, like all your partners are on board with venous disease, everybody understands what we're doing, your referring partners, and I'll talk a little bit more about that in my next talk. Thank you.
Michelle, I have a question for you. Do you have a process where you do follow-up questionnaires for your patients after they're treated? Is it phone call or is it actually something in writing?
I don't have anything formal, but when they come back into the office, we go through, what symptoms have improved, what hasn't, but we don't have anything formal that's in our practice.
Okay. Any other questions from anyone? Okay. Thank you. And I'm sorry I gave you the wrong title, didn't I? I tried to give Dr. Golan's talk away. And Dr. Golan's a vascular surgeon practicing here in Chicago. And welcome him back today. And your talk is the venous milling. Right. I mean, there you go.
Okay. Hi, John Golan. We met yesterday. Before I get started, I'll just embellish on what Michelle said a little bit. As you're trying to get your practice developed, you also have to get your name out there. And as physicians, we're kind of adverse to the word marketing and actually selling ourselves. But it's been a very effective way, at least for me, to develop my practice. We have a very active web presence. I didn't have my daughter develop my website, but I hired someone. And when you hire someone and they put all the right words in there, it optimizes your organic listings on Google so that if someone searches on varicose vein Chicago, my name is actually the top name before you get to the sponsored lists. And we also do Google marketing, or these pay-per-click items where they click and I get charged $1 or $2, and that takes someone to my website. But for me, when we did this 4 years ago, we went from having 300 hits a month to our website to having 2,000 hits a month to our website. So if you have 2,000 eyeballs a month at a fairly low cost, you wind up seeing a lot more patients. And if you're going to do something like that, you do need to measure what's called your return on investment, ROI. For every dollar you spend, how many dollars does it generate? Currently, for us, for every dollar we spend on the web, we get $8 returned to our practice, which is actually quite a high number. So, insurance, billing, what you need to know. Well, a little different. A lot of you, if you're cardiologists in particular, you're used to patients coming in the hospital having chest pain. You have the full range and privilege to take them to the cath lab and do whatever you're appropriate, or whatever you think is appropriate. When it comes to varicose vein patients done in your office, it's a little bit more complicated. You may actually just take a patient and operate on them and send a bill to the insurance company, but then you're really up to the whim of the insurance company in terms of whether they decide to pay you or not. So the best thing to do is to, as best as you can beforehand, predetermine that 1, the patient has insurance benefits, 2, that their benefits cover the procedure, and 3, that you have met the requirements that that insurance company has for that procedure. And if you do those things, you have a reasonable chance of getting paid something at the end of the day. And those of you I see who do this know that you don't always get paid what you think you're going to get paid, but it's part of the process. So the process really is beneficial to both you as a physician, but also to your patient, because patients are not happy when suddenly their insurance company paid nothing and they're responsible for a $3,000 or $4,000 charge. That does not generate goodwill within the community, and you'll find patients talk to one another, and very quickly your practice gets a black eye. You should know that the requirements for coverage of varicose vein procedures vary from insurance company to insurance company, and even within insurance companies. Those of you who know Blue Cross Blue Shield, we talked a little bit yesterday, every Blue Cross unit, and there's about, 23 in the country, has different policies and procedures for determining who gets covered. So if you look just a little bit at the treatment cycle of when you see a patient, and this is why for the physician who's only been doing this for a year and is having trouble generating business, it's a process. It takes a while. From the time you see your first patient, you have to do a history and a physical, and then the insurance companies have this mandatory conservative period of treatment where you have to buy compression stockings. You have to document they have compression stockings. For Blue Cross in Illinois, it's 6 weeks. For Aetna and Cigna, they require 3 months. It varies. When they come back for their conservative treatment visit, that's typically when we do our ultrasound on the patient, and then we send this letter of predetermination of benefits so that we know the procedure is likely to be covered. We do their procedure, and then we do a follow-up. So you can see basically from the time you first see the patient, it typically is at least 2 to 3 months before you're going to have the opportunity to treat the patient. What are the studies out there supporting this period of conservative management of the patient? There are none. There is no data to suggest that putting someone in compression stockings for 6 weeks, 6 months, or 6 years reduces the symptomatology nor improves the varicose vein condition. I think it's a delay and deny tactic by insurance companies, and it works. I mean, probably 10% of the patients we see who we send out in the conservative treatment program lose their insurance, change their insurance, move, or just decide, maybe they just don't bother them quite as much as they thought they did. With Medicare, there is no letter of predetermination, but what you do need to know is each Medicare unit has a different policy. In Illinois, Texas, and the 2 other states that are in our Medicare unit, they require, if you go to their website, a 3-month period of conservative management. If you treat someone with varicose veins in less than 3 months and you get audited, they're going to ask for their money back. But even worse, they're going to go review 30 records in your office and determine how many of your patients you treated in less than 3 months. Then they're going to go back another 3 years with that percentage and ask for 30%, for instance, of all the patients you treated. They're going to ask for a check for $150,000 back. So it's important that you document that you have fulfilled their period of conservative treatment visits. Secondly, and this is a big thing with our senior citizens, spider veins are only covered if they bled. And again, every senior citizen wants everything for free. I'm almost there, so I'm getting ready for that, but we're very black and white that spider veins are not a covered benefit. Even if they are, we typically charge 4 times what Medicare would reimburse for spider vein treatment. So how do you find out about these? you consult the insurance company's website. My practice manager every month goes to the Blue Cross Blue Shield website, which is our biggest private insurer, and she sees if there's been any changes. Typically with Blue Cross, once a year, they will come out with a new policy regarding coverage of varicose vein treatments. And if you don't look, then all of a sudden you're going to start getting a bunch of letters of denials 2 or 3 months after they change their policy when it turned out that what worked last year no longer works. Be aware again that there are regional differences. We actually, every time we get a Blue Cross patient from Tennessee who has Blue Cross of Tennessee, we go to their website and we find out what their benefits are. We know, for instance, as I said yesterday, that Empire Blue Cross Blue Shield out of New York does not cover anterior accessory and posterior accessory veins. So there's no reason to even try to predetermine for it because it's going to be denied. So the more information you have before you treat the patient, the more likely you are to optimize reimbursement. Again, they all have different policies regarding phlebectomy, different policies regarding sclerotherapy, and as I say, different policies regarding anterior accessory and perforators. So what do you need to do to ensure payment? Well, you need to document in your history, physical, and lab reports certain things. So specific symptoms. They want to know how the legs bother the patient. They want to know what they do to relieve their symptoms. And the most important thing is somehow you have to have in your note that the symptoms interfere with the patient's activities of daily living. And sometimes we'll get letters back because we didn't include the specific of which activity is limited by their veins. Now, there will be some patients who really their legs don't bother them, and we tell them that, that's great, but, your insurance isn't going to cover this, and you are going to have to pay cash. So probably about 5 to 10% of our patients actually do wind up paying cash. Next, on physical exam, they want to know the distribution of the veins, medial calf, medial thigh. They want to know the size of the veins. They want to know if they have stasis changes or C4 or greater changes, because sometimes that changes policy coverages. Presence of edema, and it's always worth checking pedal pulses. Don't just focus on what you're there. You're not a vein doctor. Remember, you're a doctor treating a patient, and the condition you happen to be seeing is varicose veins. We get sent to us 4 or 5 patients a year for, quote, varicose veins disease who in fact have claudication. And if you go ablate their greater saphenous vein in someone with a superficial femoral artery occlusion, you have done your patient no favors. These are just a SEEP classification. We talked about the C1 through C6, and basically Blue Cross in Illinois will cover C4 through C6 disease without a period of predetermination of benefits. There's no conservative management, so you can get those patients approved right away. If they just have symptoms, they have to go through the conservative treatment period. Next, you have to do your ultrasound, and again, Blue Cross is very specific about it. I mean, they're the #1 private insurer in the country, so they kind of control the market. But you have to document for Blue Cross that you examine the patient in the upright position. You have to confirm that you determined reflux based on distal augmentation and not the Valsalva maneuver. If you just say there's a half a second of reflux and you didn't tell how you determined it, you get a rejection letter. Next of all, Blue Cross Blue Shield of Illinois saying they have greater than a half a second of reflux is not sufficient. You have to say they have greater than 500 milliseconds of outward flow reflux. Now, I'd never heard the expression outward flow until we started getting our rejections 4 or 5 years ago, but your note has to specifically say greater than 500 milliseconds of outward flow reflux. And you can't say 6 seconds or 10 seconds. It has to say greater than 500 milliseconds. So they are very specific. And again, just as an aside, we always document in our record that, in fact, in the common femoral vein, we see phasic flow that augments, and that way I have a pretty good idea that in most circumstances the iliac vein up above is occluded. If you heard continuous flow in the common femoral vein, it may well be because they have an iliac vein occlusion above it, maybe from a May-Thurner syndrome, and that makes us think that we do need to do more investigation of that patient. And so this is kind of the workflow for the patient. Once we see the patient, my secretary actually, when the patient leaves, will call the patient's insurance company and make sure, 1, they have benefits. We find out, 2, how much of their deductible we've met, and 3, we find out what percentage of the bill they're going to have to pay. And so when they come back, we do it at their second, we'll either call the patient, or when they come back for their conservative treatment visit, we will talk with them and actually review the benefits that they have. Because patients basically, many of them still think, I have insurance, it's not going to cost me anything. With a lot of the newer Blue Cross plans, as they're trying to shift more of the cost to the patient, they'll have a $5,000 deductible. If they have a $5,000 deductible, they're going to pay for the procedure. We know that beforehand, we educate them beforehand, and we actually have them pay beforehand. It sounds kind of cruel, but you do a procedure and it turns out the patient owes $2,100, you know, you're going to be chasing them for weeks, months, or years trying to get your money from some patients. So at that visit, we review their benefits, we send a letter of predetermination of benefits. After they're approved, we actually send a letter back to the patient reviewing the time, the date, and actually their benefits and what's going to be expected of them. The better educated the patient is about their benefits, the more likely you are to be paid. The letter that we send has a standard letter I'm going to show you. We send the office notes, the ultrasound reports. Sometimes they require photographs to be sent, but that's a rare patient. And then we actually allow 4 to 6 weeks, depending on the insurance carrier, before we actually will schedule the patient. Although on this second visit, we will schedule them for their procedure at that time. This is kind of a standard letter. I won't read it all to you, but you can read it. You know, there's 16 ways of saying it, but the bottom line, your letter has to state that they have symptoms that limit their daily activities. They've failed to treat a 6-week to 3-month period of conservative management. Their ultrasound shows the following. And then we say what we're recommending doing. And we give the specific codes and the specific diagnoses, and it goes out. Now, if you do that, probably, and you know the benefits, probably 99% of the time you are going to get a letter back saying that this is a covered procedure, although they always put a rider at the bottom of the letter saying, even though we've sent this letter, it doesn't, you know, guarantee that you're going to be paid anything. And then at the back end, once that's all done and they're approved, we have very specific policies and procedures throughout the entire billing process, from collections to write-offs, in terms of how we manage those patients. And we write off, you know, a fair amount of money along the way. If we charge $6,000 for a vein ablation, Blue Cross in Illinois currently allows $2,100 or maybe $2,300. So there are still significant write-offs along the way. But my billing person has very specific policies, and she knows to do in every scenario. In every scenario, she knows what to do. And if there's a question, she talks to me. As I said before, we always collect cash copays at the time of service. So we know that they're going to be responsible for a $500 deductible, and we know they're going to be responsible for 20% of $2,300, and so we'll actually have them write us a check for $900 before the procedure, so we don't have to chase it at the back end. It's different than the way we practiced before, where you send a bill, you see what you get paid, and then you chase the patient. It just saves you a lot of time and a lot of expense if you do it up front. And there will be some patients who will tell you beforehand, you know what, I don't have that kind of money. Well, then, you know, they're going to wind up not having their procedure done at the time. And that's the way it works. Although I'm not as cruel as I sound, and we will have someone, if I have someone who comes in who works as a housekeeper for someone, and they have venous stasis ulcers, and they really have bad veins, and they have no insurance, you know, I might do their procedure for $1,000 or $1,500 or something that covers my costs and allows me to make a little bit of money, but I do that very, very selectively. Another thing to think about if you're not working for a hospital is we're all tied to the insurance companies, and they send us this contract which says we're going to pay you, you know, Medicare or 20% more than Medicare, and you sign here and then you're in our network. But then what do they guarantee us back for that? Nothing. They put us in their book. They don't guarantee, in any other business, if you guarantee someone a steep discount on fees, they guarantee you a certain volume of procedures. But that doesn't happen. We just sign up just so that we're in their network. So we generally are out of network for almost everyone except Medicare and Blue Cross Blue Shield. And you will find that if you're out of network, it requires a lot more work for your staff, because when a patient calls and finds out we're not in United Healthcare, we're not in Aetna, my staff is well versed on what we say, in terms of we're not a participant in their network, but we accept their insurance. We see lots of patients. The patients are very gratified, and we work with you beforehand so that you'll understand your exact financial responsibility. But being out of network, for our patients out of network, we generally collect roughly 3 times the Medicare amount. And that's without even hardly balance billing the patient anything, because the insurance company, even if they're only paying you 60% of the usual and customary, 60% winds up being 3 times the Medicare amount. So I have to basically have 2 out of 3 patients say, I'm not going to see you because you're out of network before I break even. And basically, we wind up having about 80% of the patients who call us and find out we're out of network, they still come see us and they allow us to be treated. And we're not out of network to penalize the patients, we're out of network to try to get the insurance companies to pay a reasonable amount for the services rendered. And as I say, at the end of the day, you can choose the amount you decide to balance bill the patient. We always have them pay their deductible. By law, you can't write off a patient's deductible, but after that, you can determine how much you want to have the patient pay or not pay. And we base that, we have a number that we want to capture at the end of the day for each procedure, and that's basically what we balance bill the patient, but typically it's less than $500. Sclerotherapy, it's always best if you can avoid insurance coverage for sclerotherapy, because instead of getting paid, $2,000 or $3,000 for a procedure, which makes it worth the time and the effort, you might be getting paid $150 or $200 for an insurance company, and it's a lot of work. So we'll only consider billing or predetermining for sclerotherapy in symptomatic small varicose veins. We never predetermine for spider veins. And as I said, there's a similar workload for a whole lot less reimbursements. Again, there are lots of variables between different insurance companies for who they will and who they won't cover sclerotherapy for. So if possible, we try to keep it completely out of the realm of the insurance company and try to get cash for that. So this is just a before and after of a patient, and it's very gratifying for the patient to have their leg look like that, and it's very gratifying for you as a physician to have a patient come back and suddenly have a pain-free leg that looks great and feels great all the time, but it's even better if you're able to be paid for providing that service to the patient. So remember, there is a significant cost associated with office-based varicose vein treatment. Again, I have a generator, I have laser fibers, I have a staff. It costs me roughly $600 to $700 to do one of these procedures. It's not the freebie that a lot of people think it is, but at the same time, the reimbursement is generally significant enough that it's well worthwhile. But it is critical to have office-based policies and procedures to maximize your revenue collection to have a successful business. And at the end of the day, as much as we don't want to admit it, corporate America has come to realize that medicine is a business, and we need to follow suit and treat this as a business. Thank you. Are there any questions out there? Nope. Okay, great.
Thank you, John. That was great. Well, thank you very much, Dr. Golan, and I'd like to invite Michelle back up for her second talk this morning, which is entitled Marketing of a Successful Venous Practice. And I would like to encourage everyone, too, to visit the vendor booths. We're very grateful to all the industry people who support this meeting, and it's good when you can go by and say hello and just make an introduction. So please do that so that we can continue to have this kind of educational meeting. Thanks. Where, Michelle? There you are.
Thank you.
Here, I'll take it.
So, hello again. So this part of my talk, I just wanted to give you some pearls and nuggets of what we have done in our practice over the years to market fairly successfully in Detroit, Michigan with our patients. So this is kind of a blueprint that we've come up with. There were a lot of trial and errors, reevaluating, going back, looking at everything again. I do consult and have gone to several different practices before, and everybody's set up different geographical locations and payer mixes and whatnot. But this was really kind of simplifies how to think to build your marketing practice and increase that. So we start with the partners in the practice. So we start internally, then we branch out internally to our current patients that we have, and then move out into our external who's referring us patients, and then finally into the community. So starting in your own backyard, so in the beginning with our partners in our practice, we first had to make the connection. Not only why are we doing veins? Why is this significant? Why should we be doing this? So we had to kind of educate them on the statistics that are out there, the volume of patients that are out there, and who we can help. And I really think in the future, it's not going to be cardiology and vascular. I think we're going to have a circulatory specialist that's going to be treating that whole circulatory system. So I think we're going to start to see that trend moving there as well. Don't assume that your partners know this space. If they haven't been dealing with veins or venous reflux intimately, they may not understand or know all the symptoms the patients may have. What is the process? When should I refer them to you? What am I looking for with this? We did a lot of small dinners with our own practice and our own group, little meetings, talking about, where do we want to go? What do we want to do with this? This is how we identify patients. We started internally there. How are we going to screen for these patients? What is their current practice? I know when we started working with peripheral arterial disease and we asked this question, we were shocked that some of our partners were sending their patients with below-the-knee disease outside the practice and didn't really realize what we were doing in the lab. So it's the same thing with your veins. Are they even looking for patients who have venous claudication? Do they know the difference between that? If they see varicose veins, are they referring them out? Are they sending them to their primary care? What are they doing currently with those patients? And what's the mission of the practice? So if you want to be known as this vascular center of excellence, we all need to be on the same page with that. There's definitely power in numbers. Getting the guidelines, getting some current research articles, maybe having them see the procedure, all of that helps. So not only with your partners in your practice, but now we also have to look at the office and the office staff. Dr. Golan was talking about how your reimbursement specialist and your billing, that's definitely somebody that you need to talk about or talk to if you're going to be doing new procedures and what we need. And remember, your medical assistants, your nurses, your reception, your front desk people, they're all a conduit for your message in your practice. You want to make sure that they understand and know what we're doing. I know when we would bring patients back and ask them to take off their socks and shoes, if the medical assistants didn't, the patient may say, well, why do I need to take off my socks and shoes? I'm here for my heart. If the medical assistant just said, well, I don't know because they tell me to have you do it, that's not going to look good. You'd rather them say, well, because we're going to be, assessing your circulatory system and from your head to your toe, and now we're also going to give them a form that explains some of this. So you want to make sure that everybody's on the same page with it. And this is also beneficial in keeping your program that you set up sustainable, because if somebody feels like they have ownership in it, they understand what they're doing and the difference that it can make, they're more apt to continue doing it. Seek a champion. And this, I think, is one of the key points also. As physicians, you're busy, you're doing a lot of different things. The last thing you really have time for is to be that liaison between the patients, your staff, and the goal or the mission. So somebody who can reevaluate everything. Are we hitting our goals? Are we still taking socks and shoes off? What are we doing and where are we going with that? That person that can kind of own this program. So your goals are to create that culture in your office, have that mission, and then gather the strength and support and make sure everybody is on board. So who's in your waiting room? You have these patients there. You already have a trusted relationship with them. So they're already engaged. They're sitting there. You want to capture them. Well, how do we do that? Reaching out to them already. Educational opportunities. We have education all over our office for patients, by our treadmills, for stresses, echoes. We have information not only in their exam rooms, the waiting rooms, it's everywhere. And I can tell you the posters that we put in the rooms, how many patients have actually pointed and said, oh, they took pictures of my legs for this, or I think I have this. It's very beneficial, and it's an easy way to capture and, again, start that conversation with your patients, having that information there. And if you don't have time to talk to them about it, maybe you're behind or you're addressing some other primary complaint that they have, giving them a handout or a brochure or something to give that information. And then those takeaways also. So maybe they don't have claudication or varicose veins or any of those symptoms, but their neighbor they see, they have symptoms, or their aunt. Now they're going to go and tell them, hey, guess what? I was just at the doctor's today and I got this. I picked this up for you. They may be bringing that patient into your office. Established patients can bring those word-of-mouth referrals. Again, coming back in, this is what I saw. And don't let someone else treat your patient. So that's the worst thing, is you're establishing your practice as this vascular practice, and there's a patient that's been with you for 15 years, and their primary care diagnosis is their varicose veins, their reflux, whatever it may be, and they send them to somebody else. So make sure that you're capturing all of your patients there. How many people here have education material in their rooms, in the exam rooms, in the walls? Show of hands. Okay, good. And do you find that it gets patients talking and asking about? Yeah. And I also call that kind of my backdoor tactic. We have a large practice, a large group, many different physicians in there, and some of them aren't as comfortable to talk about vascular disease. So that information that's up in the room, it gets the patient talking about it. So if the physician doesn't have time or we're not ready to talk about that, the patient can bring that up. We also have a screening form. I showed you a picture of it on the other presentation. But this Dear Patient letter, we actually give this to our patients when they come back into the exam room. The medical assistants hand it to them and they fill it out there. We used to give it as soon as they walked in, but in talking with everybody, it was too much. The patients were getting too much paperwork when they first came in, so we changed it. And that's another reason why I had that champion, somebody to go back and check with everybody. How's this process working for you? Can we make it better? So that was one thing that we changed. Then we have them take their socks and shoes off. We have little blue pads on the floor. They can, put their feet on there. And again, educating your medical assistants or your nurses or whoever's bringing your patients back and rooming them why we're doing this. When we do that annually, it's not something that we're doing every single visit that they come in. Their chart is marked that they've been evaluated for vascular disease at that point. Then once that form is filled out, the yeses and nos are circled. They can quickly look at it. The patient already has their socks and shoes off. If I need to do a quick exam, we can do that, and then move on to whatever their other primary complaint may have been when they were coming in. Again, they're screened annually. A letter sent to their primary care doctor, so you can say, I saw Mrs. Jones today. She had some complaints of venous claudication. I found X, Y, and Z. So now you're going to educate that primary care doctor also of what your practice can do and when to send those patients. And the ease of process is definitely key. If you have, and we lived through this. We've had several different processes and ways that we tried to evaluate our patients for vascular disease, and some of them were more time-consuming, some of them were resource-heavy, and this Dear Patient letter that we had, it really seemed to move through our office very smoothly. And you need to make sure that you lead by example. This is why we started internally and why I stress that to a lot of the new groups that I see. You need to practice what you preach. I can't go to a referring physician and say, I want you to screen for vascular disease, yet my own partners aren't even doing it, and they're referring all those patients out. You want to make sure that your whole practice, it puts that out there. What you are on the inside is reflected on the outside. Is everybody on the same page and feel like this vascular disease is worthy of their time? Having that internal screening program. So your referring physicians might ask you, well, how do you screen for it? How do you find your patients? What do you do? What symptoms should I look for? And knowledgeable on the testing. Do I just get a venous ultrasound? Where can I get this reflux study? How do I do that? So we talked about the partners in our practice and then our internal patients. So now moving out to those external referrers. Educating them. Again, we did a lot of one-on-one dinners where we would get our top referrers. I would start with those physicians that are already referring to your practice. You, again, already have a relationship with them. Sit them down and say, this is what we're doing now. We're branching into this. We want to provide full circulatory care for our patients. And curbside consults, you're seeing somebody passing in the hallway. If you have a mutual patient, you could talk to them about an introduction letter. So maybe you want to send out a letter to your top referrers saying, we are just have started to add venous disease to our practice. It's something that we're offering, and going through that. Or offering an open house for them to come in, visit the lab, visit your facility and what you're doing. Have them come in. Maybe if they have a patient that's going to be done, they can actually come in and see this. And we have had some physicians actually come and do that. Network and go to the disease, so new referral streams. So, if you're not seeing OBGYNs much or primary cares with young practices and young patients, but now with venous disease, those may be some targets that you want to start hitting and going to. And showing the benefits of your service. So what are they currently doing with patients with venous disease and varicose veins? Are they happy with the outcomes that they're getting for them, or do they know what different options they have? And again, just like in your office that you had that education material, making sure that they know where they can get that. So this that there's an ease of referral to your office. Do they have your business cards? Do you have brochures, pamphlets, things with information on it? Communication is definitely key in knowing what they expect. So if you do a procedure on the patient, are you just faxing over your procedure report? Are you writing them a letter? Do they have your cell phone number? Can they call you? Do they want you to call them after that you see a patient? And what is that referral process for your patients? And then just keep in mind, there's a lot of places they can go to get their veins done or with these symptoms. And you need to make sure you're nurturing those relationships with those referral sources and being a team player with them. Community outreach, this really seals that dedication that you have. It takes extra time, a lot of work to set up screening events and educational events, and definitely will bring more people into your practice. Dr. Golan had talked about the websites and the Google searches. Make sure on your website you're talking about veins. Do you have a section? Do patients know that you treat veins? What do you have that's out there? And we had done several screening events and education programs in our office. This is one that we had with Dr. Moharis, and we had a packed house, and some of these patients weren't even patients in our practice. And we didn't even really advertise too much. It was just kind of word of mouth with our patients. We had some posters and brochures that were out talking about this day that we were going to have education. And we kept it very open in general. Do your legs limit you? Didn't say, do your legs hurt? Do you have varicose veins? It was just very general and subjective. I know sometimes talking to patients with coronary disease and you ask them, have you had any chest pain? And they'll say no, but then they talk about this chest tightness that they have. So it's kind of similar to that. It's how that patient is perceiving that. But this was a very good program that we got. So in conclusion, being a center of excellence, it's not a destination, it's a journey, and every journey starts with the first step. So what I would encourage you to do before you leave here today, take some notes about what you want to do, where you want to go, what those goals are, some different things that you can do to help bring in those referrals and those patients. Brainstorm on your way home in the airplane or the car of what your plan is going to be. And what are you going to do internally? Break it down. Internally, we need to do this to get everybody on the same page and drive that mission. What am I going to do with my referring partners? Who should I go talk to first? How am I going to educate them? And then finally, what do I want to do in the community? How am I going to present myself and get my information out there? Implementing a sustainable process and finding your practice champion. Again, I think that is key because there's a lot of work when you start any new program or try to beef things up. So it's somebody that can help you with that. And thank you.
Thank you, Michelle. Thank you very much, Michelle. What I'd like to do now is I'd like to do two things. I'd like to just, the clickers on your table there, they go A, B, C, and D. We're going to do two questions and see how this works. First of all, they're just really basic questions. A, if you click A, it would be, Do you have any swelling in your legs or during the day or when you travel or sitting here? How many people in the room have actually swelling? And then number 2, B, would be, do you have swelling and or varicose veins? We'll just see how much venous disease is in our room right here. So let's click A or B. You don't have a clicker? You can get one. And it's supposed to register on the screen, right?
Some of them I think are not turned on.
Oh.
Make sure you see lights on them.
Oh, is there a light on it that says power?
The bottom left is an on-off switch.
Oh, the bottom is on off, and then we can turn them on.
Now we're starting to see answers.
Okay, let's just have a couple seconds here. And how long does it take to come on the screen?
So far I have 11 responses.
Oh, come on, there are more than 11 people here. Oh, you don't turn it on. Oh, okay. If you don't have either, that's fine, right? C. If your legs are perfectly normal, C. Oh, good. This is great. Okay. All right. Let's do one more question here. The next question I had is, have you ever had DVT yourself? And B would be, has anyone in your family had DVT? And C would be, you don't know anyone who's ever had DVT. So A, B, or C. Well, see, with those results in mind, that's why it's so important for us to share this kind of educational experience with someone who's actually had DVT so you can hear it firsthand. It's one thing for me to get up here and tell you all about the patients I've taken care of, but I show the data and their x-rays, but I don't tell you about their courage and what it's done to their lives. So I'd like to invite Joe Roberts to come to the podium, and he's going to share this time with us, Dr. Chopra, to express with us some of what it's been like for him. He's in our realm. He's in industry. Some of you may know him. And Joe, I'd like to ask you if you'd like to share a few things about
Thank you.
PE and DVT personally.
First of all, I'd like to thank Dr. Thorpe for giving me this opportunity and also for the mentoring and the knowledge she's imparted to me over many years, ad nauseum sometimes, I'm sure, for her. My story begins, first of all, I've spent most of my working career in product development for a device company. So my story with DVT actually begins in the early 90s when I listened to a presentation from a dear friend who unfortunately died 2 years ago by the name of Renan Uflacher. And he had presented a paper on dysfunctional venous valves and chronic venous insufficiency. And I was shocked that I knew absolutely nothing about a disease that affected so many people, and that I had been involved in catheter-directed therapy from a development standpoint at that point for almost 15 years. And a perfect storm formed right after that. I was aware of Dr. Thorpe's work, and I contacted her, and she introduced me to the human side of the disease. She showed me her patients. I remember one patient in particular whose leg was a large man who was a lineman, and his leg was 2 or 3 times normal size. And he was a young man, and I thought to myself, you know, how could I not know about this whole patient population? Also, as a result of that, she sent me to a wound clinic, and that, you know, most of the people in this room, I'm sure, have experienced that, and that was a real eye-opening experience as well. So I got very interested in venous disease, and thanks to Dr. Thorpe, Dr. Hunter, Dr. Uflacher, and the pioneering people who were doing that work 15, 20 years ago, I learned more and more about the disease. And within probably a year after I went to this presentation, a good friend of mine who was a world-class athlete, he played in the NBA, developed DVT in his late 30s, went undiagnosed or misdiagnosed, and he was in a hospital bed at 2 o'clock in the morning and asked the nurse in the room to please help him because he thought he was going to die. He couldn't breathe. And at that point, they diagnosed submassive PE. And to fast forward, that totally changed his life. He went from a world-class athlete to someone who has maintained a level of conditioning, but it totally changed the way his life, his activity level has changed dramatically. So we'll fast forward now to 6 years ago. And for most of those years, I kept up with venous disease, and I tried to learn as much as I could about it, and I was very interested in, the more I learned, the more shocking it was to me how underappreciated and undertreated it was. So I went in for a hip replacement, and hip was replaced. About 2.5 weeks later, I presented with swelling, redness, pain, warm to the touch calf, and I went into the emergency room, and the doctor told me, bad luck. The ultrasound tech has just left. So he said, I don't think you're at great risk for any issue with this, so I'll give you a shot of Lovenox and come back tomorrow at 10:30. So I went home, went to bed, woke up in the middle of the night, short of breath, sweating, went in the next morning, and a different ER physician told me, you have pulmonary emboli in both lungs. So I went from there to the pulmonary unit, which I spent the next 3.5 days, some part of that spitting up blood and being very frightened, short of breath, and going through that whole process. My life, from the standpoint of having DVT and being compliant from the standpoint of wearing compression stockings, taking anticoagulation, and doing all of the things I can do after having been treated conservatively, changed my activity dramatically, and it changed my life dramatically. And the company I work for, since I was in the capacity of product development, the message within the corporation was that we were going to dedicate resources to whatever device development we could possibly develop to help treat this disease. And since I had the DVT and PE, we have probably had 12 people within the organization that have had DVT and some with PE. And as your knowledge base expands, without belaboring this, because I know I've been added on to the program late, but I consider it a blessing, actually, that I've had this experience, because I'm in a position where I can work with, and there are many people in this room that have enhanced my knowledge of venous disease and have certainly added to increasing my voice within industry to tell my story and tell others the same story, that this disease affects a broad range of people, and many young people and many normally healthy people, until they develop a blood clot. And if the blood clot is treated appropriately, they don't have to develop the disease in many cases. So that is my story. I think I have told you everything that has impacted me about this in a reasonable amount of time, but thank you for the opportunity to share my story.
Thank you. I have a question for you. So do I. I have a question. Thank you, Joe, so much. It brings a humanity to this discussion. But do you have any signs and symptoms of post-thrombotic syndrome?
I do.
And because you were not treated with lytic therapy at the time.
I was not.
So tell us what you live with.
My symptoms have been, well, as I mentioned, I've been very compliant because I've had the luxury of Dr. Thorpe and Dr. Hunter and Dr. Chopra and other people who have advised me, make sure you do these things. And I've worn the compression stockings, but in spite of that and the anticoagulation, and now I'm taking aspirin and I'm doing some massage that Dr. Hunter spoke about yesterday. But I do have pain, I have swelling, I have itching. I don't have any skin changes that have been diagnosed. But those are my symptoms.
Now, Joe, you're in a very unique position that you can provide a perspective that now you're a patient, you know enough doctors, and what is the mindset of a company? Because companies drive everything here, even this education that we do. What is the perspective of a company, and how do they take a problem like this and take it to product and then disseminate it to get more activity? Did I make sense, or?
It does. It makes a lot of sense. And I think there are a couple very daunting things about this from the standpoint of cost and regulation and going forward, because we're all aware that the ATTRACT trial is being done, and it's, I think, 50 or 60% completed. Hopefully the results of that trial will be compelling, but after listening to Dr. Razavi this morning, you know, there are a lot of questions about how industry, government, insurance companies will embrace the endpoints in terms of improving, you know, quality of life and all of the issues that have been discussed. Our company is a privately held company. We don't have to, and I don't want to get too commercial with this, but we're not beholden to, you know, stock shareholders, and we don't have to look at something with a short-term outlook. So we're looking at this over a 10 or 15 year perspective. But I think one of the biggest issues, two issues, will be public awareness, referring physician awareness, and data that will be compelling enough to make insurers look at that and say, well, you know, obviously these people will go on to lifetime disabilities and they have serious complications from this. But I think everyone's trying to sort through that. And I don't know if that's a good answer, but our commitment to it is we know there's a very human face to it within our company because of the people that have the disease, and certainly my voice, I tend to talk a lot. I don't know if I make a lot of sense, but
Yeah, you do.
the joke within the corporation is that I got so interested in DVT, I got it. And I don't know if things happen for a reason, but as I said before, I feel very blessed that I'm able to be involved in this program.
Thank you so much for sharing that with us.
Thanks.
Okay. Now, thank you, Joe. There's just going to be a minute here while we change gear. Dr. Bjornson's here, Dr. McNamara's here, and we're going to shift into some DVT talks.
Thank you, Dr. Thorpe, and I would like to thank the organizers for inviting me to come to this symposium. I will be moderating the late morning session. We'll talk about deep vein thrombosis and pulmonary emboli. I will start by giving a 10-minute talk on phlegmasia cerulea dolens. Phlegmasia cerulea dolens is a rare entity. I've, during my 20 years of being involved in this, have maybe seen 5 cases of this. I've been involved in management of maybe 2 or 3 of them. It is somewhere in between regular deep vein thrombosis and venous gangrena as far as the clinical presentation goes. It is slightly more common amongst men. This is obviously not very scientific, but based just because of how few the patients there, is probably most common amongst people in the age group of 50 to 60 years. Left-sided is more common than right-sided, not surprisingly, given the incidence of DVT. And it's a triad of symptoms, which I will mention slightly later. Clinically, the affected limb is tense and firm to the touch. The skin is purplish in color, and the patients may develop blebs and bulla. They typically get very severe pain symptoms, which may be difficult to treat with pain medication and leg elevation, and arterial insufficiency with subsequent venous gangrene may follow. Now, this is a picture of a patient I saw quite many years ago with a very advanced presentation of this syndrome. The main risk factors, and we will come on touch on this a little bit later, is malignancy and hypercoagulability, not surprisingly, but there are multiple other risk factors identified, and then there is a considerable amount of patients that do not have any of these identifiable causes. So what is the background for this syndrome? It is increased hydrostatic pressure caused by the occlusion of the outflow veins. It becomes, for some reason, more extensive than in patients with regular, uncomplicated, if I can use that phrase, deep venous thrombosis. The interstitial pressure may become very high, and it is debated what is really the underlying pathophysiology, but it is thought that the smaller arteries or arterioles will become collapsed because of the high hydrostatic pressure. There may be some microvascular thrombosis also involved, and some people have speculated that there is a spasm phenomenon also. And this obviously becomes very important when we think what treatment options should be applied. So early intervention is very critical, and going back to the previous slide, just think about what those would be. There are a plethora of things that have been attempted, including sympathectomy, antivasospastic medications, and other medications, just to indicate how challenging the treatment is and how little we actually understand about the pathophysiology. But what we know for sure and goes along with the treatment of deep venous thrombosis is we need to prevent any further propagation of the thrombus. We have to also decrease the underlying cause for the increased hydrostatic pressure, so try to remove as much of the thrombus as possible. And many of these patients will develop systemic hypotension, so fluid resuscitation is important in the general management of these patients in the acute phase. So anticoagulation, not surprising, but the surgical or pharmacomechanical thrombectomy are probably the key factors in the management of the acute syndrome, and we will touch on this later. I will just go through this one case that I showed you in the beginning to give you an introduction to those patients that we encounter with this entity. This was a patient with cancer, a very severe form of peritoneal cancer, and developed a very rapid symptomatology, which is presented here in this picture. This was the extent of the thrombus, so not really significant if you look at the ultrasound outcomes. The iliac veins were actually not involved. Even the common femoral vein was not involved. It was the femoral vein and the popliteal vein and probably some extension into the calf veins. She also had thrombosis on the non-symptomatic right side. This was, if I remember correctly, in 2004, and we were then in the heydays of starting popliteal vein punctures. We decided to do that. We did mechanical thrombectomy, And we had also been playing with puncture into the posterior tibial vein by the ankle to try to clean out the popliteal clot. Because of her severe swelling and collapsed vein, we were not able to do that. We were able to do mechanical thrombectomy and then left infusion catheters in place to try to clean out as much of the thrombus in the femoral vein as we could. We then punctured, we placed the patient then on her back again, punctured the ipsilateral common femoral artery and did an angiogram of the affected left limb. It was interesting to see how slow the flow in the tibial arteries was. It was like a hammer going to and fro, and we left an infusion catheter also in the artery for infusion. And the reason I give you this example is just that I want to demonstrate to you the desperation that follows treating this severe case. This is the day after the femoral vein had cleaned. We did not have much flow from the popliteal vein, which we were not able to treat, and there was still a very slow forward flow into the tibial arteries. The patient subsequently died and represents these numbers here, very severe prognosis in these patients, and you can see that up to 50% of those patients will get amputation if they survive. Just because of the fact that there is not much data available, I have decided to present this article, which is from 2011, a meta-analysis of sort. They looked at 393 papers and were able to find 32 articles with 62 patients to represent this cohort of patients. Malignancy, as we mentioned before, and hypercoagulability are the most common reasons for or underlying causes, but there is a good number of patients where we cannot find any good reason for the development of the thrombus. And 30% of the patients had pulmonary emboli already when they were admitted to the hospital. They stratified the patients into 3 groups based on the severity of their symptoms when they came. Non-complicated only had cyanosis of the skin. Number 2 also had blistering skin, and then we have the most severe form with necrosing or gangrena. This is a complicated slide, but it shows you which group, clinical group, the patients that developed or had improvement in symptoms belong to. And you can see that the patients in group 1 and in group 2 had a very significant or a large proportion of these 2 cohorts. The patients with the least symptoms had very significant improvement from the treatment that was applied, and I will get to that later. The patients that belonged to the more severe clinical entity had a less favorable outcome, and you can see that 26% of these patients actually died. Malignancy was also more common in the patients that subsequently died. And so let's now look at what treatments were applied and try to make some sense out of the outcomes based on the treatment modality that was applied. A considerable amount of these patients did get a surgical thrombectomy, and you can see that we had a fairly high number of patients that actually died in that group. Those were probably also patients with very severe symptoms. But a respectable number of patients did get clinical improvement with surgical thrombectomy. There was also a sizable number of patients that did undergo thrombolysis, and some of them a mechanical component to the pharmacological thrombolysis. And here you can see that there's a very respectable proportion that actually did get improvement. 1 patient died, and 2 patients did undergo amputation. Fasciotomy, though, this is a population that clearly has very severe symptoms when they present. You can see that many of these patients actually did undergo amputation, maybe representing the severity of their symptoms. And finally, there are a few outliers that underwent angioplasty alone or stent placement alone, but the numbers are small. I just wanted to put out this reference here just to make you aware of the fact that thrombolysis by itself is not completely benign in this population of patients. This was a case report of 2 patients that died as thrombolysis was advanced and the blood flow started in the limb. As a conclusion, these patients that have any symptoms of phlegmasia need to be intervened on early. Aggressive anticoagulation needs to be started right away. I think a very appropriate way of approaching these patients is to start them on a thrombolytic regime, probably catheter-directed. I would advise that you try to get the calf thrombus and the popliteal venous thrombus addressed as soon as you address the more central thrombosis. And finally, surgical options are still there in the patients that have very severe symptoms. And I would like to thank you for listening to this. I would like then to ask Dr. McNamara, somebody I haven't seen for many years, to come here up and to talk to us about management of DVT. Thank you.
Good morning, Geraldo.
Dr. Goodwin's running late, so he's going to give his talk after Dr. Triple, so they're just going to switch the order. Okay, thank you.
Good morning. It's a bit like trying to preach to the choir. Everybody here, I think, is probably predisposed and or convinced that the first treatment for a DVT, particularly iliofemoral DVT, should be thrombolysis and or thrombolysis plus aspiration in one way or another. However, it's not really up to us in that we're not, for the most part, at the in the front ranks, although that actually there is a qualifier there, that if you're in a radiology practice, you would be performing venous ultrasound, so you may well be the first person to be make the diagnosis, and when we do, we call the physician and make this as a suggestion, and somewhat to my surprise, consistently, the physicians will say fine, particularly if you're willing to take over the care of the patient in terms of admitting them to the hospital, taking care of them in the hospital, and then maintaining their initial progression to oral anticoagulation. Actually, there's very little opposition to that, which has surprised me. But if you're going to try to get not just that individual who you call, but the mindset in the community to change and/or the mindset in the emergency room, what data is there? And I'd like to review that with you. We won't go into any tips and tricks. Is interventional treatment better than anticoagulation for DVT? Well, despite what I've just said, in fact, if you look at clinical practices and what happens to people, such as Joe, when the diagnosis of DVT is made, they don't get lysis. And why is that? Well, actually, patients improve relatively quickly if you put them at bed rest and put them on a heparin or its equivalent. And you can actually now do this without putting them in the hospital, which of course that's a big driver now, more perhaps than it should be, and that is the cost, the money. You can avoid hospitalization. Everybody's persuaded to look very hard at that therapeutic option, which would be Lovenox home and get on to Coumadin. Also, for the most part, the primary care physicians that you'll be speaking to have had very little exposure to this type of treatment, very little exposure, increasingly less as there's more and more mechanical ways to try to take someone to the lab either for artery or vein disease, boom, get it done. There's a big emphasis on that. That's a great thing. And it is good, but perhaps it's gone overboard a bit in terms of clot treatment. And also there's a fear, I think, for those of us who are quite experienced, as Geraldo mentioned, overly done fear of bleeding complications, and as Mahmoud mentioned as well, it's way over. It's not that it's zero, but on the other hand, the true incidence is greatly exaggerated in people's minds. And those who are selling mechanical devices, they'll contribute to that exaggeration. And the other thing is increasingly, as particularly arterial interventional treatments are now being performed by surgeons, by cardiologists, which is great. Nonetheless, there's a diminishing number of interventionalists, and most interventionalists are in general radiology practices. And as reimbursement for just the professional part of these treatments continues to be pushed down, the money you can generate doing an intervention as a physician in a radiology group pales compared to somebody who's reading in a darkened room and being pretty efficient. So there's a lot of reasons why this is true, and they're unfortunate. But according to the arbiters of what should and could be done for treatment of venous disease, for reasons that I don't really understand, the American College of Chest Physicians are the people who published sort of the Bible on that. A few years ago, after years and years and years of people like myself and Harolder and Joe saying, you know, you should really recommend as a proven method of treatment thrombolysis, they've now clicked over. And now they do list as a primary treatment, not the primary treatment, but as an option in the primary treatment category, thrombolysis and mechanical treatment for iliofemoral thrombosis. So what do they know that the average physician doesn't know? Well, they know they've reviewed all of this. And part of it is looking at the incidence of post-thrombotic syndrome. If you look into this, and when you see talks, you can see if they list a range of reported incidences of post-thrombotic syndrome following DVT, the numbers, they'll report a range, which is surprisingly wide. Well, how can that be? Truth shouldn't be that hard to pin down. Well, they use different endpoints for one thing. PE as a definition of a recurrent post-thrombotic syndrome, recurrent DVT, patency, and the definitions of post-thrombotic syndrome differ. Joe hit on them: pain and swelling. That's it. But people differ in how they'll define that. Quality of life, follow-up periods. Okay, what's the incidence of post-thrombotic syndrome? Well, if you follow patients for a year, be different. If you follow them for 2, 3, 5, 10 years. All of those things are in the reports, who reads the reports? Usually it's headlines. Different locations. The American College of Chest Physicians is now recommending DVT treatment, thrombolysis, and clot aspiration for iliofemoral. Well, it does differ. The incidence post-thrombotic syndrome following that's much higher than if it's just popliteal, or if it's iliofemoral and popliteal, then it's actually worse, as you might expect. Or is it just popliteal and trifurcation? Each group has different, and it's not made clear to the reader often what they're really talking about, or in comparing numbers. And there's differences in compliance. Does compliance make a difference? Joe is wearing his stocking. He's remained on anticoagulation way past the time that the average primary care physician would recommend. Is that going to make a difference in, not necessarily pain and swelling, but probably in that, probably reduces the incidence of recurrent DVT, and also, by being compliant as he is, he's going to reduce the chance of developing lipodermatosclerosis and or venous ulcer. All of those things impact on post-thrombotic syndrome, and they're often not made as clear as they should be report to report. This is just an example. On your left, there's increasing incidence of post-thrombotic syndrome, red arrows pointing up. All those bars are different colors because they're different time periods post the DVT. So on the far left is the red bar, the incidence of post-thrombotic syndrome when a patient is followed for a year. Far right, incidence of post-thrombotic syndrome, group of patients followed for 12 years. So they do vary, but none of the numbers are good. Criteria for diagnosis of post-thrombotic syndrome: pain and swelling. And it's required that they be there 6 months afterwards. In that, some patients with acute DVT are judged to be having their pain and swelling for as long as 6 months. Also, after 6 months, it has to have been present for a month's duration. That's just the criteria. Somewhat arbitrary, no doubt. Valvular incompetence, reflux. Most reports of the incidence of post-thrombotic syndrome don't require that. Obviously, if you do require that, the incidence of post-thrombotic syndrome might be lower if you have to have both. But even if you do require both of those, the incidence is still 27%, 1 out of 4. Not good. The incidence after anticoagulation is if all he received was, as Joe, anticoagulation, standard treatment, can't get sued yet for having done just that. Should be, probably. Gene Strandness was a vascular surgeon, but a real pioneer in the use of Doppler to diagnose vascular disease, in particular venous. Made huge contributions there. He reported incidence of post-thrombotic syndrome based on pain and swelling as 2 out of 3 patients at 3 years. 15 years later, a man who studied under him, who's also very respected, Mark Meisner, reported 73%, following a little longer, 4.5 years. And as I mentioned, if it's based on those things, signs and symptoms plus valve incompetence, still the incidence is 27%. Now, post-thrombotic syndrome relative to location, as we mentioned, the iliac occlusions actually rarely completely recanalize. Usually, you can look at the image either on ultrasound or on a CT angiogram, which is never really high resolution. Nonetheless, look like it's open. But if you get in there to try to go through it because the patient's symptomatic, you're planning on probably putting a stent, your guide wire doesn't easily go through. At least it seems to me you're generally encountering like a delta. It's just a maze of synechia surprisingly often. They prove as you're trying to traverse them to be far less truly wide open than you would have thought. And I was introduced to that concept in the country of Colombia. I was invited down there a couple times to give a talk and was talking with, and what can they know? You know, we're the greatest, we know the most. But people are smart everywhere. And this fellow who was making a living as a phlebotomist educated me that you actually get more complete thrombolysis endogenously and with anticoagulation in the femoral veins than you do in the iliac. I never forgot that. And as I came back with that having been suggested, I watched for that, and I think it's actually true. And I think that's one of the reasons why it makes sense to, for sure, do thrombolysis for the iliofemoral thrombus. Anyway, post-thrombotic syndrome at 5 years was 44% reported by Meisner if it's iliofemoral. Post-thrombotic syndrome, 44%. And at 10 and 20 years, longer follow-up, 50 to 80%. And that's why the American College of Chest Physicians has recommended treatment. Venous claudication reported as being as high as 44% by Dulles in the American Journal of Surgery. And a recurrent DVT, at least double if it's a iliofemoral thrombus as opposed to just fem-pop. Probably because it's the cork at the top that's giving the whole leg stasis. So that justifies that. Post-thrombotic syndrome and venous ulcers, they're reported to be at 25 to 33% of all DVTs. Ulcers are at least 4% by 20 years. These are different authors, so the numbers are all different. Does, however, account for 6% of home care in Canada, that is to say venous ulcer. And as it has been mentioned by, I think, Mahmoud, 2 million workdays are lost per year secondary to venous ulcers. Huge, horrible problem for those of you who've had to work with these patients. It's a terrible, it's a heartbreaking thing. And interestingly enough, the patients seem to find their way to surgeons and follow up more often than to medicine. So the incidence of these various problems, post-thrombotic problems, usually is lower in publications that internal medicine physicians submit to. 23% at 2 years in this one, 9% severe. Surgery reported a much higher incidence, as I mentioned, and as has been mentioned, and what will be a driver, and Mahmoud alluded to the complexities of trying to justify treatments based on cost. But Haidt reported 12 years ago that the cost for post-thrombotic syndrome care was $300 million per year then. So a lot of numbers. This is Gene Strandness, just a tip of the hat to him for all of his wonderful leadership, and to Dr. Thorpe as well. The benefits of thrombolysis, I think we'd all accept, are that you can save the valves. And the American College of Chest Physicians recommends treatment within 14 days. It's hard to be certain of any group of days, but that's what's recommended. That should be paid for. And it is hoped to save valves. I'm not sure what the proof for that actually is, but in our own clinical experiences, it would seem to be true. It does prevent stenoses, and that's a whole other talk, but actually a lot of these irregularities, some changes in spontaneous phasic waveform in the legs as people breathe and you're looking at them, are predictors that they do have underlying problems that if you could actually address, Patty uses a regular balloon, I have I have axiomatically thought the cutting balloon would be better, and that is what I prefer to use. At any rate, these stenoses are really significant. Obvious stenoses are more common in the iliac than in the femoral vein, but the femoral veins lesions are also significant. Now, if you can, with thrombolysis, save the valves and prevent the stenoses, you don't have what Dr. Stranda said was the worst combination: one, bad valves, and obstruction. And lysis will reduce or prevent both. And, I should go back perhaps, but I'll just say it. If you save the valves, you don't have to wear the stockings. People don't like it. And also, with both of those things, you don't have to use warfarin for as long a period of time. Standard treatment, patient who, a young person, just went on to birth control pills. Just standard thrombolysis, 46 hours, clot's gone, valves look great. It's not tough treatment. There's all kinds of ways to do it, but just standard, melt it, do nature's way. It works real well, and you'll often then uncover the underlying problem, which is actually extremely well seen whether without or with contrast CT scan showing the artery compressing the vein. Actually almost better than regular than venography. Accelerating lysis, there's lots of ways to do it. A simple way, which really just lets the drug and time do the work, is with the ecosystem. It's been purchased by another company. I certainly believe that you could even do better than it currently does. There are those who love the other devices. I find the other devices very helpful, but I like to use lysis for 12 to 24 hours first. Less clot. What's left is a clot that I think is more easily aspirated. That's my own personal belief on that. The results with the ECOS, we don't have time to show you things, but it's documented to cut the dose and the time in half, and I think that technology can be made much better. Stockings really do reduce the incidence of post-thrombotic syndrome and or the severity. But they only reduce it down to 25 or 33%, better than twice that, but even in patients who are compliant, it's only down to 25 to 33%, Joe being an example. And compliance is poor. People don't like them. Anticoagulation, run into a lot of controversy. Patients will come back to you and say, well, I was following your advice, taking the low dose of Coumadin and the aspirin, but my doctor said, why are you doing that? That's not right. Don't do that. And the next thing you know, they come back rethrombosed. On the other hand, you don't need those things if you have used the lysis. The recurrence and post-thrombotic syndrome is less than 10% if you initially treat them with lysis. I ran over, I apologize. So thank you very much.
Thank you, Tom, for a very comprehensive overview. Okay. Yeah, Dr. Ansari will give us an update on new management tools for the treatment of deep venous thrombosis and pulmonary emboli.
Okay, so just a little update on new anticoagulants in regards to the medical treatment of thromboembolic disease. Really don't have any disclosures to give for this topic. Just quickly, I just want to go over some of the definitions, and that's really relevant to actually the treatment of venous thromboembolic disease. But the spectrum of DVT and PE really involves the origination of thrombus in the lower extremities and the majority of cases of DVT, and actually that forms across the valves inside the lower leg. DVTs can really be broken up into two categories, whether they're proximal or distal. The proximals are really those above the level of the popliteal vein. Calf DVTs really qualify as distal DVTs. The pulmonary emboluses actually originate far more commonly from proximal DVTs, and the PVT and PEs can be classified as either massive or submassive. And for the purpose of this talk, I'm really just going to be doing submassive PEs because those are the ones that are really qualified as hemodynamically stable. The massive PEs really get a lot of times consideration for lytic therapy and whatnot. The clinical spectrum is quite wide. So whether that really goes from the diagnosis to the treatment to the follow-up for the spectrum of DVT and PE. And again, really, I just want to focus on the medical treatment. So I really don't have anything, really sexy to give. So the most I can really picture is Betty White holding a bottle of Coumadin, but not like the trellis device or anything like that. But anyway, the background, again, the rate of diagnosis for PE is increasing dramatically in the United States. And in 1998, that line across those curves was really with the advent and introduction of multi-row CT. So we've had a lot more diagnosis of PE, and we've had a lot more treatment of PE with various anticoagulant regimens or lysis regimens or catheter-directed regimens. However, that bottom curve is actually the mortality outcomes from PE, and those have not changed. So it's universally recognized that DVT and PE is diagnosed, there are some probably clinical situations where it's clinically not important to treat DVT and PE. Maybe the lower ones, maybe asymptomatic ones or whatnot. Getting more specific with the background, it's fairly common to have one of these events, 1 to 2 cases per 1,000 persons. It's the third most common cause of vascular death in the U.S., so that's after heart attack and stroke. May cause up to 10% of in-hospital deaths. The good news is that recurrent events are really reduced with treatment, and the standard regimen really consists of parenteral medications, whether that be Lovenox or unfractionated heparin, with an overlapping regimen of vitamin K antagonist, that's Coumadin, and that of course has to be modulated. The duration of therapy really dependent on the risk profile of the patient, and this was recently updated in the 2012 CHEST guideline physicians document. It's also well known that the actual patient preferences actually influence treatment, and it's also known that the availability and cost of pharmacological agents actually influence treatment. So it's whether or not, now with hospitals being part of the system and whatnot, whether or not they have the medications on formulary or whatnot, that actually influences some of the choices that you can give your patients. So just more background on the standard regimen, but this is actually kind of laying the case for the newer anticoagulant agents for their introduction and whatnot. And, I think everybody's pretty familiar with these medications, but, typically for the parenteral medications, whether that be the heparinoid family, including fondaparinux, which is synthetic, heparin-like agent, the one negative for that is that it has to be administered subcutaneously, and that's really not ideal for long-term use for the treatment of the patient. They are highly effective, though, and that's been proven since the 1960s. Coumadin, has very many unsatisfying characteristics, I would say, as far as when you're administering that to your patient, and that's that it has a relatively slow onset of action. People often give a loading dose or whatnot, or then they don't know what to give for the second dose. The dose response is really unpredictable. There's multiple interactions with foods, multiple interactions with the drugs, specifically cardiovascular drugs, which I think most of us are familiar with giving, and there's a narrow therapeutic window, so it requires frequent monitoring and then frequent changes to the Coumadin regimen. Only about half the time are patients therapeutic, so that's in that typical value range of 2 to 3. And it's been well known also that there are thrombotic events when people are subtherapeutic, and there's bleeding events when people are supratherapeutic. The other aspects of care is that it used to be done in the hospital. People were admitted for a fairly long amount of time while they were getting appropriately anticoagulated with Coumadin, but now that's really done at the home with subcutaneous injections. People were oftentimes seen by specialists like pulmonary doctors and whatnot. Now that's really transitioned into the general medicine field. And oftentimes, it's not even a board question anymore, like, how do you treat this, or how do you, DVT or PE or whatnot. And lastly, even when pulmonary and critical care was actually seeing these patients, it's now really being transferred to the Coumadin clinic or the anticoagulation clinic. So really the long-term management is really not something that we're practicing on a day-to-day basis very actively. The issues with this is that your risk of having a recurrent event after having a single episode increases steadily over time. So at 1 year, 5 years, and 10 years, your risk of having another thromboembolic event is increased in a very linear fashion, up to about 40% at 10 years. And the risk factor really on 1 year even and over long term actually depends on kind of your individual risk characteristics. So whether or not you had a major reversible cause as your etiology, then your 1 year event rate is fairly low. If it was unprovoked, then you're somewhere in the middle of having that and having cancer, which can lead to up to a 30% recurrent episode. And unprovoked is basically an undiagnosed PE or undiagnosed etiology for having a DVT or PE. So this is just a summary slide of that, but basically, whether if it's something that's something reversible, then really that only qualifies now for about 3 to 6 months of therapy. If there's an unidentified risk factor, the CHEST guideline physician's document would say that you can do 12 months of therapy or you can do longer. And then if you have an active cancer, then those are people who should be considered for lifelong therapy. And it's because of that and the unsatisfying characteristics of Coumadin that we've really developed the newer anticoagulant agents. And so those are specifically the direct thrombin inhibitors and the factor Xa inhibitors that are orally administered to the patients for a long-term basis. A few years ago, we wouldn't be able to give this slide or even have this like update talk, but now in the last 4 years, there have been significant number of journal publications for randomized studies that have looked at individual agents, and I basically listed those here. Just to go specifically about this, one thing to note is that the dosing administration is quite different than that given for the same agents that are studied in the atrial fibrillation trials. So each of these, just to go back a slide, if I can, I don't know where I'm pointing. Each of these agents has, a stroke thromboprophylaxis study that was done in the setting of non-valvular atrial fibrillation. But the dosing, and I would just caution that, is that it's actually quite different for that. So dabigatran was studied in the RECOVER study that looked at about 2,500 patients individually. All these were non-inferiority studies, and they looked at the standard regimen of Lovenox with Coumadin compared to a kind of a 21-day course of Lovenox and then switching to the oral anticoagulant dabigatran. The reason why the study was done this way is that there was a previous study with another direct thrombin inhibitor in Japan that found that there was, in the short-term setting, a significantly higher number of events when people tried to use that oral anticoagulant as monotherapy. And so there was no dosing study with this. It rather, and the way that's administered is after 21 days of giving low molecular weight heparin, you give then the oral anticoagulant at twice-a-day dosing. But it was non-inferior. I think one of the things that was also interesting is, opposed to the RELY study, there really wasn't a signal for an increased amount of acute coronary syndromes in this study with the agent. Of course, there was a different dose, so it is something to consider if that was an issue. And then from the bleeding standpoint as well, there were actually very favorable outcomes. If you look at the two qualifying types of bleed that they had, either a major bleed or any type of bleed. So major bleed was qualified as having a 2-gram drop in the hemoglobin or requiring 2 units of transfusion. The dabigatran actually compared very favorably to Coumadin. And then also for any type of bleed, they're actually quite similar. And really for the rivaroxaban, which was the first oral 10A agent that was approved in the United States, very similar studies shown. It was a non-inferiority study that looked at actually a twice-a-day loading dose of rivaroxaban and then a single-day or single-time dose. And that was compared to the same combination of Lovenox and a vitamin K antagonist. And that again showed that, for non-inferiority, it reached a specific endpoint. And then for bleeding outcomes, actually, it was very similar. Same thing for the rivaroxaban PE study. So this study, they kind of broke this up into, instead of reporting everything in one, I think 2 is better than 1. And so they did a DVT and an extended study therapy study, and then they did the pulmonary embolus study. And in both cases, the non-inferiority endpoint was met, and then the bleeding outcomes were actually, for any minor type of bleed, actually favorable for the oral anticoagulant. Apixaban is the newest agent, and again, it was the same type of thing. This is just a summary slide. Really, I think some of the things to keep in mind is that the protein binding is actually quite important because of the purposes of reversing these agents. So dabigatran actually has the least amount of protein binding, whereas the other agents are fairly highly protein bound. So if you look for the antidote and whatnot in the second to last column, you can see that officially there is no antidote, which is the worrisome cause, for many institutions. But for reversal via hemodialysis, dabigatran actually has, potentially or theoretically some possibility. But officially, there is no specific agent that reverses these agents. Some thoughts that have been put out in the literature are that if you have a bleeding event very quickly after an ingestion, so within the first hour or so, you can give activated charcoal, and that may reduce the absorption. Again, as I mentioned, dabigatran is the least protein bound, and hemodialysis may be successful in removing this. However, because of the large volume of distribution, which is estimated at approximately 40 to 50 liters in a patient, there may be a rebound effect. Recombinant factor 7A has been given in case reports only, but there's concern for DIC and systemic thrombosis. And then PCCs, which are kind of, 3 or 4 or 5 factor kind of mixtures of concentrates, have been shown in a randomized study to normalize the PT in rivaroxaban, but not in dabigatran. So, clearly I can tell you from my institution, we actually tried to get, I work at Cook County, which is not known for being leading edge or anything like that, but we kind of played safe. But we actually tried to get these agents onto our clinic because our Coumadin clinic has about a 2-month wait time and whatnot, and we, after initially approving it, actually the surgeons actually revolted, and they said we're not going to touch people who are actively bleeding who have had these medications and whatnot. So it's a lot of politics and whatnot. I mean, certainly I think if we look at the objective data, the bleeding outcomes certainly aren't any worse, and I certainly don't see any of these same issues with Lovenox. It doesn't seem like there's a readily accessible reversal agent for that as well, but that seemed to not have much impact in my institution. But it's just something to consider as far as when we're treating our patients with this. But just to summarize again, the safety and efficacy data is now there with these newer agents. So I think the traditional regimen of Coumadin and Lovenox does not need to be so. The FDA has approved rivaroxaban only at this time for the treatment of acute DVT and PE. The other two agents are not approved at this time. There was actually a release about 2 days ago that said the FDA has some concern with the apixaban data in China, and I think it's going to be delaying the approval if it does get approved for apixaban for the treatment of acute venous thromboembolic disease. I think the one thing to mention, especially for the cardiologists in the audience, is that we do have to keep in mind the dosing regimen. If we, if this is part of our practice, what we're going to be treating, it is quite different than that from the thromboprophylaxis from the atrial fibrillation studies from the same agents. Again, the use has to be individualized to each patient. And really that has to factor in the patient needs, the desires, the cost, availability of the agent, and whatnot. And the other thing to keep in mind is that there's really no definitive reversal agent. That's it.
Thank you very much, Dr. Ansari. I would like to ask Dr. Chamberlain to come up here. Dr. Chamberlain will give us a crash course or teach us how to do thrombectomy with angiojet at home.
All right, at home. It's all outpatient, really outpatient. I would disagree. I think that these new agents are sexy, so very nice. And really, I think it's changed. These new agents, you can, all this, excuse me, waiting around the hospital for days for Coumadin. I mean, just the incredible waste of the money and time has gone away. I mean, in a couple hours, someone will be therapeutic. So I think it is sexy. All right, DVT. Angiojet, I was asked yesterday to give this talk, so this is the best I can do really fast. So, but I love this stuff. I've been doing this for a long time, and I've been using the Angiojet ever since we had it when I was a fellow back at Loyola, and I watched them grow the device and get bigger and bigger ones for bigger and bigger vessels. So let me share my thoughts. First of all, Dr. McNamara very nicely covered all this, but it is a big problem, and I agree. He very eloquently talked about the problem of finding or getting people to agree to let you treat these patients, and it seems crazy, but it is. It's the biggest problem because really, preventing pulmonary emboli and preventing post-thrombotic syndrome, those are the two biggest things, and I think this is the hardest thing to tell them, early, is that please let us treat this now. It's so much harder treating this, a couple months down the road. And unfortunately, most of the people I see come to me 2, 3, 4, 6 months down the road, and then it's much more difficult. So with the Angiojet, it's one of the mechanical options that we have. I think that what's interesting about Angiojet is the second part here, which I'm just going to mention, because I think it's a lot of people are doing it now, is kind of this mechanically assisted thrombolysis, using the Angiojet to actually deliver a thrombolytic. But Angiojet alone, it has of the suction devices, it's the most powerful one we have. As a handheld suction devices have kind of come up for coronary cases, they don't really have the ability to remove as much clot as you want from especially these large diameter vessels. And he has to talk about it a little bit more here later, but a lot of this has to do with the size of the vessel. You have to match the catheter to the vessel. And if you're a cardiologist using a small Angiojet for acute MI, you have to remember that that's for a small 3-4 millimeter artery. It's not going to do anything in a big DVT. So you have to be aware. You got to use the other devices and be aware of what else is on the shelf. Just real quick for those who haven't seen, how this works. Basically, it's the Bernoulli principle. Actually, I'll just show this little video, let it play, and it kind of tells the story. I liken this to the this little shower head here. You're basically running fluid down here to the shower head. It moves straight back, more proximate to the catheter. And as it's running this fluid over the opening here, it creates the Bernoulli effect, a huge amount of suction and entrainment. And then with the newer catheters, they added these little holes here to kind of shoot some water out and break up some of the clot. So the combination is you have a lot of suction and you remove clot. Now, if you think about it, well, what would come out? Well, a fresh, soft clot comes out quite nicely. Clot that's been there a long time, well, it's going to be harder to break that up because it's gotten very fibrotic, and so that's your wall, that's your limitation. So just to show kind of the variety of catheters available, and again, the XMI, these down here are coronary catheters. Don't try to use those for DVT. The Solent Dista is a new one. It's really made for arteries in the feet. I mean, distal, it's a really long catheter. And again, it's quite strong, but it's really made to go in small arteries. You want to really focus on these bigger ones. Now, this biggest one is AVX, is for AV access grafts. But the Solent Omni and Solent Proxy are really the current large vessel thrombectomy catheters for angiojet. And these go through 6 French sheaths. The Proxy is 90 centimeters long, Omni's 120. And just a note here again about power pulse. I think there's a talk in the arterial section about this, but it's quite helpful for DVTs. What you're basically doing is you're basically injecting the clot with a thrombolytic. So basically, the new machine, used to be we'd mess around with the stopcocks and do this, but now they're all FDA approved. They're set up for this on the machine. You pick out your bag of TPA that you're going to use, and you go down and you basically inject every centimeter 1 squirt in the whole clotted segment. We typically do 10 milligrams in 100 bag is what we do, I believe. And then you got to walk away. You got to leave it sit there for a good half an hour and let it marinate. So you're going to marinate. We're going to leave, and let it do its job. And then you go back and angiojet, and without taking any pictures, go back and angiojet right away. And all the free thrombin that you kind of loosened up, you can remove, and this can really lower, and I'll show you a couple studies, it can really lower your treatment time. It can shorten things up. I saw one of those slides from McNamara's, 46 hours of lytics. Oh my God, patients hate you on that 45th hour. So it's whatever you can do to shorten these up is helpful. So this is one way you can kind of do a quantum movement on the amount of clot. Again, there's a couple trials I want to mention. This is one that looked at this using thrombectomy versus thrombectomy or pharmacomechanical lysis using the thrombectomy catheter to deliver the lytic. And they really showed that significantly you shorten your duration of treatment over here, and the amount of dose they use urokinase then, and just the number of procedures, and more significantly, and the cost actually is quite lower. And more significantly, bleed wasn't too, I guess it's on the next one. They talk about the actual time in the unit. But basically on this one, they show you actually have less bleeding because it's that time under the curve of giving all that thrombolytic for all that time. People have more bleeding problems. And another trial looking at this as well. What was interesting at this, they did show some of the similar, this is looking at long-term patency and all that. But I thought what was interesting was I think it is, the time in the hospital. I mean, it dramatically shortened the hospital stay, the time in the unit. All that time when you have a catheter in a vessel, dripping thrombolytics, and you're waiting for the bleeding to start. So it can really be quite dramatic. So let me show just a couple cases, and I really think there's a couple things that really make angiojet very helpful, and I think that you got to kind of measure your expectations. This gentleman came in, quite interestingly, he had swelling in the leg for a while, but a lot of negative Dopplers. So what does that tell you? He probably had an iliac problem first that they couldn't see, and then he showed up when he got finally a positive Doppler. So one of the big issues, my issues with this is the time of the clot. The clot's been sitting there. If you can get there early, you can get them not to just start, Xarelto in the ER and go home and see me in a month. No. Just if it's a whole leg, he's got swollen up to the thigh. You want to get on this right away and treat it quickly. So here's what he had. He had occluded his iliac vein. We kind of knew that from kind of his exam and history. And then we took a couple pictures down the leg. There's a lot of fresh clot up and down his femoral vein. So what we did, we just angiojetted all that femoral vein, and a couple of runs, we really got a nice result. And for everyone who's done this on all the patients you've seen, this is not that common to get this clean of a looking vein. So it told me a lot about his history. Like, this was new. This is fresh clot in the last day or so, and it all came out nicely in the leg. So, and it kind of let us focus on the real problem. That was his iliac vein. And he had cancer. I was worried either with his treatment or the cancer itself. Something was going on in that iliac vein. So this picture on the left here is after lysis. So it wouldn't stay open after angiojet. So we lysed it overnight, came back, a lot of fresh clot around the catheter. So this is new fresh clot. So we went in and we angiojetted all that, and this is kind of what we got. So this is his baseline vessel that's there, and I think this has probably been ballooned at least once. So what we decided to do initially was leave it alone, knowing that he's got cancer, he's being treated for it, anticoagulate him. And even with anticoagulation, he came back and closed the iliac vein. And so at this point, we said, he's got a problem. We're going to have to stent this. So we cleaned it up, laced it, and placed a couple of stents and got this open. But we knew, his mortality from his cancer was showing itself in his aggressive behavior here. I just want to mention this as a filter issue. Somebody mentioned, I've caused PEs when I've done, angiojet of iliac veins. I go, well, that's true. It could happen. And what I've done is, and now we have so many nicer removable filters. You can put them in from the neck, take them out from the neck. A lot of times, if it's a big iliofemoral DVT, I'll put a temporary filter in at the beginning, just put it in, and then go to work on the leg and leave it there till you're all done. You can take it out. Sometimes 6 months to a year later if you pick the right one. So this is just an example that filter. I like showing this to filters are not the answer. This is why they're now removable, because if you leave them in forever, they're a nidus for clot, and then you end up just cleaning the filter out. Speaking of filters, this is an interesting one where he had a filter placed by a surgeon without really. I don't know what they did. I don't think they had. They may have had an X-ray machine, but I don't know how they placed this. You'll see why. He was not put on Coumadin. He'll protect him with the filter. It'll be fine. This is what he did. It's a little hard to see, but you see this Optis filter obviously placed really low. It's covering the right common iliac vein. He's clotted all through this common iliac vein, this iliac vein, and the IVC. Everything's clotted. So what we did is we kind of went both sides. We crossed over, angiojetted from the right to the left through the filter, angiojetted through the filter, stuck the other side, did the opposite, and dripped some lytics. And so this is a progression after some runs with angiojet, runs the opposite direction, and eventually we got it to this point. So we got as much of it out of there as we could, and try to get him to stay on anticoagulation after that. But again, this avoided, if we just lysis, I think that this would have been a 2-3 day procedure. Angiojetting, removing fresh clot quickly and limiting it, was an overnight procedure. So that I think is the biggest value. Conclusion, I think you should be aggressive about these. And I really do think a lot of this is your hospital, your the pattern of where DVTs get diagnosed and how you talk to them. And you need to really spend some time at the primary care and reassure them that we're going to jump on this right away. We're going to treat them quickly. They're going to have a nice result, and they're going to not have persistent pain and swelling forever. And we can help things and try to preserve those valves. All right, any questions?
Any questions? Thank you, Dr. Chamberlain. Dr. Mark Goodwin is giving a talk next door. Or has he arrived again? Then I would like to ask Dr. Mark Goodwin to step up to the podium. He will talk about the trellis device for management of DVT.
sure they're rearranging the slide deck order.
One moment, please.
Yeah. So while we're waiting, let me run a case by you guys. The 61-year-old with sarcoma with a filter placed 5 months ago came into our hospital, and about 3 weeks ago, he has a sarcoma in his left leg with metastasis to the lung. Surgery wants to remove the sarcoma and say it'll buy him extra 2 years of life. He had a severely swollen left leg, and at angio, he was clotted all the way through the filter. We lysed him for about a day or two. Then he had a small, it was a tremendous amount of throat, did everything possible, and he had a tiny retroperitoneal bleed, so we're bringing him back next week, and the issue is, I don't think the filter's gonna come out just by how it looks and how it's sitting, and the junk in there almost looks like metastatic stuff. Would you guys just stent open the filter to try and reestablish flow?
Any comments from the audience?
Yes. This guy has as much clot as I've ever seen. He formed all this on Coumadin with appropriate anticoagulation. So his sarcoma obviously is not being his friend in this particular situation, but he can't get surgery on the leg to remove the sarcoma because the tissues won't heal because the leg is so swollen. So I'm just trying to get, if people would just stent it just to get some decompression of the leg and then, put a filter or something in later on for him, just so he can get decompression of the leg so he can have the sarcoma removed. They say it'll buy him a 30% chance an extra 2 years with it. So I just wondering what people thought.
Any other comments from the audience?
Okay. Yeah, that's what the issue is. Anyways, I'll move ahead here. This is going to be use of the trellis device. I think each one of these tools, you sort of need to have a toolbox full of tools. Each one has its own little niche and its own little advantage and disadvantage. These are the disclosures. Dr. McNamara covered a lot of this. We're sometimes slow to adapt. This is June of 2008. Recommendation from the ACCP, which has always been relatively conservative. Use of catheter-directed therapy for acute iliofemoral deep vein thrombosis, recommended. The thromboreductive strategy you have, I don't believe in, obviously none of us do, in systemic lysis. It's catheter-directed, mechanical and thrombo-mechanical, surgical removal, angiojet, trellis, ECOS, and vortex. Probably most of you don't have vortex. I've used vortex about 4 or 5 times. It's a large 18 French vacuum cleaner that you literally suck the clot out into a pump, and the pump has a filter, so you require 2 venous cannulas. It's like going through a bypass pump. It works pretty good, particularly with huge vegetations on wires for pacemaker leads. It works great, and I think for the vena cava, I don't think it works well for the PE because it doesn't make that bend very well. Most of the stuff was covered, but this is once again, a lot of times you have to look for the underlying venous problem and not just take it at face value. Just because you lyse it, you still want to, in most cases, potentially do an IVUS and go forward. So here's the American Heart Association recommendations from 2011. This is not probably occurring nationwide, but this was the recommendations. If you have common deep vein thrombosis or iliofemoral deep vein thrombosis with compromise, you should be transferred to a center as a Class 1 recommendation. We don't get a lot of Class 1 recommendations in the world. I doubt your hospitals are filling up the ERs with people being transferred in for lysis. CDT or PCDT is reasonable for thrombus extension despite anticoagulation, and CDT should not be given to most patients more than 21 days. Although I agree with this, I've done multiple people late in their onset. I'm not going to show one guy who was a soccer player who had a back surgery 3 years ago. He can no longer play soccer because of chronic venous symptoms. So his DVT had been 3 years ago. And lysed him, and he's back playing soccer now. So on specific individuals, if someone's job, dependent if they have to walk a lot and they're on the leg, and you get these people with severe venous claudication, they're so life-limited they can't perform their job, then I think you may extend the indications. skip the stenting. So this is a trellis device. Basically, the idea behind it is you see the two balloons. So we're going to put a balloon up and a balloon up, and we're going to inject TPA in there, and it vibrates. It looks like a springing sprinkler from when you were a kid and you run into a sprinkler, but it doesn't really swing. It just vibrates. So the idea is to create mechanical and lytic therapy at the same time while not exposing the body to systemic lysis. The TPA sits within the segment that you're inflating the balloons on. These ports, the major port that you see closest to the device is the port that you're going to aspirate after you run this for 1 minute, 3 minutes, 4 minutes. You're going to aspirate the clot out, and I'll walk through the steps of that. The device itself, you see one is an on button, that's one upper left. The right circular button is how fast you vibrate the device. And the lower bar slides up and down. It changes the orientation of where that thing is vibrating. So it's just ways of trying to disseminate more TPA throughout the thrombus. So this is a young girl who had a DVT about a week post-abortion. She has a massively swollen left leg, so she's laying prone. We've stuck her popliteal vein. I tend to go popliteal vein on the really massive ones. Just find it easier to get, it's pretty easy to access under ultrasound. The vein is so engorged, and you'd obviously want to use ultrasound because you don't want to stick the artery because then you're already behind the 8 ball with potential bleeding complications. You can see there's really no flow getting through to her. This is the trellis device. You can see the balloon up. You want it to look sausage-shaped, so you're going to keep expanding the balloon. The dye you put in there, I'll show the concentration. It's about a 1 to 3, 1 to 4 concentration. You want it to fully, like a sausage, oppose against the vein. So it may look different in different views, and I'll show you one interesting shot in a little bit here. This is after doing some, now I've established flow to her, and this is her post picture. After we've stented her. She, by IVUS, did have a May Thurner, which I think is far more common than I probably ever knew, and probably missed it a lot in my life before I started IVUSing these. So DVT lysis, the step-by-step thing is to do a popliteal vein under ultrasound with micropuncture. The micropuncture needle is easier to see under ultrasound than a regular needle. It has a different, the metal composure is different, so it has a little bit easier, I think, to see under ultrasound. Put in a 6 or 8 French sheath. I tend to go with an 8 right away. You can start with a 6. The 8 just gives you a lot more flexibility. When you get to the larger wall stents, you're going to need to go up to a 10 to 11 French sheath. The popliteal vein will easily handle that. But just so you know, you're going to need larger sheaths as you get up. There's no go venous sheath stent yet. There is a company in Europe, it's not Biomedics. I think it's Biomedics that makes just a vein stent. And several of the manufacturers are looking at changing some of the properties we have for venous stents here in the U.S. I use a glide wire with, I use quick cross, any cross catheter is fine. Sometimes it's a balance here. There's a little bit of force sometimes needed, particularly with some of the old chronic stuff. So there's a balance between, shoving and nudging. And you want to nudge. Sometimes you want to nudge a little harder than you may want to nudge. But as a general rule, I think the vein tends to be pretty forgiving as long as you don't let the wire get out into some collateral in front of you. Then you want to angio, make sure you're true to true. The whole gear here is you want to always get true to true, whether it's common femoral vein to the vena cava, whatever it is, you want to get flow to maintain patency of whatever you're going to do. I believe in liberal use of the IVUS. It's important to get through to the area of free clot. It also, I think, helps you understand the timing of the DVT as to whether it's new. As Jack just showed, there's characteristics that are going to make you clinically approach the case differently based on new, recent, or old. And then you place an exchange wire. You introduce the trellis device. So basically, it's a catheter. You move the guide wire, and then there's a dispersion wire that you insert. The key about the dispersion wire is it's a very flimsy little wire that does the vibration. So you want to use very short strokes. Don't take big strokes because you'll bend that wire, and I can tell you it's a nightmare to play with then. So it's short strokes with getting the dispersion wire in. Prepare the TPA. Typically, you're going to be giving TPA during this. You're going to inflate the proximal and distal balloons using the green port. There's 2 green ports. That's what you inflate the balloons with, and it's a 25% dye until you see the balloon flatten. You want to put about 1 milligram of TPA through the red port, and then you turn it on. I turn on the device, speed and direction of time. You can deflate the distal balloon, then aspirate. You want flow coming in there as you aspirate, so you're going to aspirate out the clot. Go back up with your distal balloon and repeat it again. Typically, I'll repeat it maybe anywhere from 5 to 10 times, depending on what kind of progress I'm making. The whole idea is to speed up so you're not doing a really long overnight 2-day infusion of lytics. Repeat the angio, and then stent as needed. There was a different slide deck. As I'll show, do you have another slide talk of mine? I'll give you the conclusion before I show 2 other sort of interesting cases. I think lysis is safe and appropriate in a lot of clinical situations. I tend to use the popliteal approach for the really big venous thrombosis, liberal IVUS, and I think trellis allows a safe mechanical lytic thrombectomy while minimizing systemic effect of the lysis. Is that the new one? Yeah, I'll clip through to some slides here. So this is a interesting girl. I'm not going to show the whole thing. She had presented with a DVT. She'd flown to Sweden. She was 29 weeks pregnant. She had a fairly large DVT. It was placed on Lovenox. I think there's 2 teaching points here. She came in to get, she was going to get a delivery electively, or they were going to try and induce her as original plan. And so she came in to get a filter because we knew she had an ultrasound that showed a large extensive DVT. I had not seen her subsequently. So she was coming in electively to get a filter so she wouldn't have a problem with delivery. And the angio before this, when I angioed her, her whole vena cava was filled with thrombus. She originally had come in with a small PE and a large massive DVT. Teaching point there is, although she was sent on Lovenox, you do need to check factor 10 levels on Lovenox in pregnancy because of their hypercoagulable state. The typical weight-based adjustment may not work. So you want to make sure that you look at that. That was not looked at. The baby was viable, so they delivered her that day. She had a hugely, hugely swollen leg with obviously occluded vena cava. So 2 days later, I started lysis on her. This is the trellis device, as you can see here. But I really want to zoom in. Right there is the May-Thurner syndrome. It's the first time I've really captured it with the balloon being on top of the web. It's her left leg, so she is laying prone once again. So her whole cava had been filled with clot. After the initiation, and so this is a fairly chronic, acute on chronic type of clot. After the trellis device, you can see we've now created a channel. Worked with that with some balloons, lysis, stented, and she's done great. Saw her in the office. Baby did great. She did great without any particular problems. This next one, unfortunately, the stent's not going to show. He's an interesting guy. He had bilateral iliac occlusions, a 49-year-old guy. Stented him, sort of bifurcating stent in the aorta. 8 days later, on aspirin and Plavix, he developed an acute DVT. And so did a trellis on him. His was pretty recent clot. Already had a pretty good channel, just so you can see the trellis is still in there. IVUS, he had a clear cut. You could see the stent where the May-Thurner was. There's a lot of variations of May-Thurner, as you'll hear. I don't know if there was a talk earlier today, there'll be one later today. There's a lot of variations of May-Thurner, so we all know the one type, but there's multiple variations. Clearly, you could see sort of the stent where the May-Thurner was. There's already scar tissue in the vein, and we were able to open it, and he's done well since then. So as I said, I think it's safe. I think it's a product for DVT that allows you not to give systemic effect of the lytic elsewhere and allows you to sort of speed up the lysis of the vein.
Thank you.
Dr. Goodwin?
Yes?
I have a question for you, and then I have a mic for anybody else who wants to ask a question. After you do the trellis, do you look with the IVUS to see what residual thrombus is there? Because the venogram, in my experience, looks better usually than the vessel does on the inside. And so does that ever change your the way you do things to put a catheter in overnight and clean up the residual thrombus?
There's a debate later today on whether you use IVUS or not. I think you hit it on the head. When you take an angio, it always looks better than the IVUS does. For me, it's a matter of creating enough flow that I think that I can get a stent in and get reasonable flow through there. I think by IVUS, you almost never totally clean up all the clot. So it's a combination of me of both, an angio and IVUS. The IVUS, I want to know where is the May-Thurner or web at, because you want to extend beyond that. It's important to get it into the vena cava. I think we all underestimate where that might actually be. So I normally mark it on the screen exactly where it is, so I know that my whatever stent I'm in makes it into the vena cava and beyond it. And these are really hard to, I had one guy one time just to deliver the stent, I had to go to about 20 atmospheres just to break the May-Thurner to be able to get a stent through it. So when this scar tissue builds, it's really tough. So I think if you use the combination of the two in your mind of, okay, I have enough clot lysis that I think I can establish reasonable flow, that's the time to, I don't think you're ever going to get to a picture where it's perfectly clean in terms of IVUS.
Well, I've seen many cases where you run a TPA overnight with a unifuse catheter for 12 hours, 18 hours, and the next day it's incredibly better.
Yeah, so the point is, to your point is, on the acute DVTs, most of those are clean up relatively quick. If you still feel you have a reasonable clot burden, then what I normally do is use an infusion catheter. I tend to use higher rates, so I really dilute it down. So I might put 5 milligrams in a liter and run it at 200 cc's an hour to really try and get as much flow through the catheter as possible with as minimal amount of TPA. So it's really sort of, if I still see a lot of clot, I'll let them cook overnight and bring them back in the morning to stent them. If the clot looks like it cleaned up a lot, then I'll stent them at the same setting.
Okay, anybody else have a question or a comment along this line here?
I was just wondering with regards to the to trellis, in my experience, whenever we use it and we use the aspiration port, really tend not to get out too much, especially in clot that's older, like 3 weeks. So we've been using like large bore guide caths afterwards and advancing them over wire, and then we've had a lot of success with getting out tremendous amounts of thrombus, and then overall, the results afterwards, both angiographically and then clinically, end up being a lot better. I don't know if you had a comment about that, whether...
Yeah, I've used it. When I first started doing it, I didn't take down the distal balloon. And since I've started taking down the distal balloon, I will say it makes a difference in how much I aspirate. In the beginning, I was just sort of thinking, the stuff's in there, I aspirate. And it's really sort of a closed system with nothing flowing in and out, and I wasn't getting anything out. Since I started taking out the distal balloon, I'd say probably more than 50% of cases, I get a pretty decent amount of clot out. A lot of these cases are sort of, each has its niche, and you're sort of throwing the kitchen sink at it and trying to do it safely. So I do get clot out now that I open the distal balloon. When I first was doing this, I was stupid, and I didn't open that, and I thought, oh, it's a closed system, I'll just suck everything out, and it didn't work at all. I think the times you run into a problem with all of these, the chronic clots, the 2-, 3-year-old clots, those are always difficult, and those take a lot of work.
Very good, thank you. I'll maybe take that question off base. The next talk will be given by Dr. Trouble. He will give us an introduction into hybrid thrombectomy for venous DVT, for DVT.
Well, good morning to everyone. Just want to say I got nothing to disclose. So, we've heard all about percutaneous thrombectomy, which is a great thing to do, and when we look back, we can see the evolution of trying to get the thrombus with the basis of removing it so we can relieve the obstruction and prevent some of that venous reflux that will develop in the future. And initially, they started with the thrombectomy, then they started lysing. And so but there's a bunch of people that are really not great candidate for lysis, and I think this is the approach we should be thinking of, okay? Let's say somebody had a cabbage last week. Now they have an acute iliofemoral DVT. Are you comfortable giving TPA to that patient? Spinal surgery, removing a tumor in the brain. So those are the cases that you might want to think about this approach. They went all over the issues on post-thrombotic syndrome and when you're treated with only anticoagulation, and we're clear that that's probably not the best approach for these patients, okay? You have an issue of of creating an obstruction that will lead to an incompetence that will have a devastating effect on quality of life of the individual. So the evidence is robust that removing the thrombus is the best option. And when you look at the recommendations, the ACCP has gone to as far as to recommend it. Then in the 9th edition, they back out. They said it's only for people who had like a real phlegmatic limb or a impending venous gangrene, which I don't know if you've seen those patients, but most of them don't ever leave the hospital. So those I'm not sure, because I treated a couple of people with venous gangrene, and unfortunately most of them recur regardless of anticoagulation. It's really not a good case scenario. They usually have a bad malignancy that will either keep them in the hospital for a prolonged period of time, or they will die soon. So I think I disagree with the 9th edition. We'll see what happens with the next edition of the ACCP. Okay, what's going on? Oh, there you okay. So, when we look at venous thrombectomies, we have to look at the few later publications. Dr. Camarota explains his approach, and it's very interesting the way he does it. He creates 3 incisions, one in the groin, one at the popliteal fossa, and one at the ankle. And what he does to deal with the fact that it's difficult to deal with the valves, you don't want to come retrogradely through the valve with a Fogarty catheter, right? So what he does is that he will pass a Fogarty up first, and then with a little angiocat, put 2 Fogartys in, inflate them, bring the other Fogarty down, and then inflate the Fogarty down and pull the thrombus out. This is quite a technique, but it requires 3 incisions. You can confirm that the thrombus is out by venography, which is an advantage of this, but the disadvantage is 3 incisions. You got an incision in the groin, one at the leg, and one at the calf. 3 areas to bleed. So that's the thing about that. One of the latest approach that have been described. Dr. Alimi and Haktoum, they're in Marseille, in France, and they have a great deal of experience with venous thrombectomies, and their approach is ingenious as well. They do a single incision at the groin, and then I don't know if you've seen the orthopedic surgeries that are done bloodless, where they actually exsanguinate the blood with the leg with the big rubber band, and they start at the toes, and then they go all the way up to the groin. And then after they've done that, they open the vein and literally milk the thrombus out. But, what's the default on that? The issue with that technique is that they don't have confirmation that actually all the thrombus came out. They can maybe think they got enough thrombus, they're pushing, they're not getting anything else. So it's one incision, but you're not sure that the thrombus is completely out, okay? So, okay, what am I doing here? I'm having trouble with this little thingy. So catheter-directed thrombolysis is obviously the option, okay? When you only do catheter-directed, which nobody does anymore, right? You've seen it. People use the angiojet, others use the trellis catheter, others use the ecosystem, and they all work very well. You need primarily a technical expertise to do it, and number 2, most of them you will use TPA, right? Combining different techniques will actually provide you with better result than just one technique. So I will say that it is a great approach. It's good. You've seen the pictures that you can get with this thrombus that is very acute. You clean it all up very quick, right? But then what happens when the thrombus has 20 days, 21 days? You probably will benefit from what the lady was saying earlier. She was asking about doing IVUS. That's probably because it has some thrombus that is older than the one that is immediately in the lumen. So putting a catheter there, it will definitely, if you have some residual, it will clean it up and you will probably get a better result. So combination of techniques is actually better, right? And it is important to get as much thrombus out, because the more thrombus you remove, the better it's the result with regards of quality of life. Okay, if you don't have near complete occlusion, you will definitely improve the quality of life of that individual will have, but he will still develop post-thrombotic syndrome. Okay. So I will show you my approach. You know, the first time I did this approach, it was a cabbage AVR. He had a massive swollen leg, so I decided to do something else. And I had thought about doing this previously, I needed a technique that I did not use TPA. There was no need for TPA. Probably I would require an open approach. But I wanted to do something that I could see my result. So I devised this way of doing it. So I present you a 68-year-old female, came in with a diagnosis of chest pain. He had a bad valve, had an MI, had the cabbage, and AVR performed, you know, typical comorbid conditions. And after a couple of days, from his surgery, he developed a swollen leg. So the way I approach it, I do a groin incision. I go straight down to the common femoral vein. The common femoral vein, I try to get access to the profunda and the saphenous vein. You know, they're right there. It's actually, when you see the common femoral, you've seen it in venography. There, it's like a trident. The three, the femoral, the profunda, and the great saphenous. So that's the spot where you want to go in, because that's actually the first valve that the patients have, that we all have. Right at the level of the saphenofemoral junction, that's the first femoral valve. The iliac vein and the common femoral vein do not have a valve. So what I do is that I take a needle. Once I have the vein access, I take a needle, I put it in the common femoral vein, and with a wire and under fluoro guidance, I pass a wire through the valves, okay, and all the way down to the tibial veins. When I'm at the tibial veins, the most important thing here is that you don't want to lose your wire. You put the wire down the tibials, and then I pass a 7 French sheath, 45 centimeter long, over the wire, and put it all the way down to the popliteal or the tibial vein, depending on the area that I want to clean. And then you take the dilator out, and you can actually fit, through a 7 French sheath, you can fit a 4 French Fogarty, a 4 French Fogarty with this 035 wire, okay? So when you do a venography, which you can do with the glide catheter before you pass the sheath or through the sheath, you can see that this gentleman had, you know, the femoral vein, the iliacs, everything was occluded. So I pass the Fogarty down, I take the sheath out, I pass the Fogarty down, and I use a long wire, a 260 glide wire, stiff wire. And what I do is that I put the Fogarty down, I inflate the balloon, and I pull both Fogarty and sheath at the same time, but I have somebody hold the wire so I don't lose wire access, because then you have to do the wire access, which is probably the most difficult part of this, going through those valves, okay? So you keep moving back. You can see the Fogarty and the sheath. You keep moving back slowly, you know, you wire, sheath, access, little by little. And you can see how it looks under fluoroscopy. I try to get some guidance to make sure that the wire doesn't come out. And this is what you get most of the time. Sometimes you have to pass the Fogarty a couple of times. I don't know why, you know, after the first one, the thrombus doesn't come immediately out. You pass it a second time and a third time, and sometimes all of a sudden you see the whole thing comes out. One thing that I do is that when I'm not getting a good result with the Fogarty, I pass the sheath down, and I just flush it out. A big syringe, push saline water out, and the thrombus comes out. That's how you clean the popliteal and the femoral vein. And so for the iliac veins, what I do, you know, this gentleman had a May Turner, but some people think, okay, what happens when you're manipulating on the iliac vein? I'll tell you that you know, flow will go to the less pressure area. So the air or the room has less pressure than the cava. So thinking that you need to protect the common iliac vein to avoid thrombus going up, I don't think that's necessary, okay? When you open the vein, the blood comes out. And if you don't see blood coming out, it's because it's obstructed, so it's fine. So for the iliac veins, I use a 6 French Fogarty. I put a 8 French sheath, short one. I do my venogram, pull the thrombus out. If you have like a May Turner's, you can balloon it or stent it, depending on what you think will be best. So it gives a good result. And more important than what you see venographically is that the patients come back and they have 0 swelling, okay? So, you know, they feel well. Regardless, I always put them on stockings to see how they, you know, just to make sure. I keep them on anticoagulation, that's typical. So I'll tell you that in my results, I've done about 25 cases of these. I have about the same complete resolution of the thrombus that you will have with with the typical technique of using isolated segmental like the trellis, or using angiojet combined with catheter directed, you know. So it is a good technique. I like it, and I recommend it. Okay, here we go once again. So for this, I can tell you this technique will remove the thrombus. You have as good of a result of doing it percutaneously. You have, I think the pharmacomechanical combined with catheter directed is superior to catheter directed alone, and that this hybrid approach is at least as good as a combination of other techniques. So I think it's a nice technique, it's simple, it's effective. It does avoid valve damage, because that's always a thing. You think that if you're manipulating the valves retrogradely, you might be damaging the valves. Well, you know, the only way to know that is actually to get those veins out and look at them in the microscope to see if there's mechanical damage. But is that really important? I don't think so. I think what's important is whether you're having femoral vein reflux or not. And I've checked most of my patients, and you know, most of them do not have reflux on the femoral vein. So I think manipulating the valves retrogradely is not a problem. It does avoid thrombolytic therapy. And I'll tell you what, I don't know if you know, but TPA costs about $2,000 a pop. You know, one of those 50 milligram vials. So I can assure you this technique will be cost effective. Okay? So, but that analysis I don't have.
Thank you, Dr. Martinez-Trabel. Yes.
Yeah, thank you. In the interest of time for the luncheon, we'd like to take any questions you have for the panel this morning regarding the talks that have been given, and Dr. Grady has graciously agreed to go in the afternoon with the wound care section. So are there any questions here? You know, we have a nice luncheon. They're set up, and a lunch and learn, which I think is going to be next door, right? So, Dr. Bjarnson?
Any questions?
So
Yeah,
we'll,
I
we'll
would like to
adjourn, yeah, go ahead.
thank the speakers, and thank you for staying.